Welcome everybody, great to have you here. This is the key to getting all your basic NOT locked down. So our commitment is to help you, assist you, and hopefully give you a wise conceptual understanding of where you're moving to with the NOT process. I was talking to Dr. Feldman just a moment ago about technique recipes, and we've certainly got a great soup here. It'll be on my kitchen rules soon enough. And we want to give you a concept to work towards. So we want to give you some big picture concepts that you're running towards as you start to use the Module 1 information and then bring the Module 2 information in. Because in Module 1, we kind of gave you the structural keys. We taught you about all sorts of elements, thank you very much, Dr. Mack, that are the fundamental pillars of getting that structural body sorted out. And in this seminar, we're going to take you through how you heal, regenerate, and protect yourself. Okay, so this is our day. Day 1, we're going to do all those things. Like I said, we're going to review Module 1 and then look at our protective systems. And then tomorrow we're going to look in a bigger way at this limbic concept and our digestive process, and then the action of our valvular system in moving food and digested metabolites. What we're doing is reorganising disorganised patterns, and we say disorganised, they're kind of adaptive patterns that we've all got stuck in. And I think that's the nature of being human, is that we get stuck in all sorts of patterns because our smart body is doing its best to deal with whatever we are driving it through. Remember, we had these 3 brain levels. This is going to come into the picture a bit more. Had our reptilian brain, our adaptive systems, where our kind of cranial nerves operate through maintaining all of our basic functions so that we can survive. Midbrain, our limbic system, our relating interface, which we'll dig into in more detail, but essentially it's controlling our growth and repair. So if people aren't getting better in your practice, I'm not getting better, doctor, I don't feel better, part of it will be in this zone, in this relating system. And remember that we're trying to get this cortical brain fired up, because the more activity we have at the top, then we tend to inhibit our, kind of unwanted relating behaviours like fear and anxiety, and all of our adaptive or over-adaptive stress responses get turned down. So when we've got healthy sensory feedback, healthy afferentation, then the information passes through the relays in the midbrain, hits the top, and comes back and turns those down. Now, it doesn't matter what technique you're doing, that's what you're doing all the time. And you need to kind of just keep that in the back of your mind there, because it's when we don't have this, that's when people start to not get better. Or, doc, I did so much better and now it's all come back again. We introduced this concept, pattern recognition theory, everything from a PRS to the limbic corrections we're going to show you tomorrow, are part of our nervous system's ability to integrate patterned information, and for that information to train our brain to do something specific. We talked about hemispheric dominance, or what happens when we adapt hemispherically, and we started to introduce this as one of the things that changes, if you like, which side we tend to lateralise on. So if you've got an atlas subluxation left or right, will be tied up with this motor output and its regulatory control, which all, at the end of the day, is interfacing with limbic. So this is a key. The brain has an inherent subtle motion within, and as does the entire body. Every muscle is attached directly or indirectly to the skull and spinal column. Cranial therapy can affect the 12 pairs of cranial nerves, which in turn run our vital functions and the whole body. So that's what we're moving towards. We started to get some stability in our cranial system at our last seminar. with our cranial injury corrections, well, really to begin with our category 1 corrections, and then into our cranial injury or centering reflexes and cranial injury. So I want you just to kind of keep that in the back of your mind, particularly this concept here that we can influence these cranial nerves. We showed you the cranial motion there, eloquently created or recreated in this Mark Pick presentation, and we'll be influencing that today. Particularly take notice of the sphenoid bone. One of the keys with the NOT system is that we are at a really basic level trying to restore these rhythms. It's going to be a little different to your standard listing chiropractic system if you're a senior chiropractor. There's a few of them in the room. And you can bring all of that into that care process. But what we're trying to do in a really kind of basic initial way is restore that craniosacral pump, get that meningeal system operating again. And we're going to develop that today, and we'll show you why it makes such a big difference to the outcomes you get with people. It's not instead of everything you do, it's as well as. But if you funnel this into your practice, and I know some of the chiros are, then people will get better outcomes. We had a look at the primary respiratory mechanism, and we had a look at it from a perspective of removing the bone and then letting the system pump and watching the meninges move with it. We stuck some bones back on to start to get an understanding of the craniosacral rhythm. You look at the brain moving. Look at how much those reciprocating membranes are moving in the skull and getting that fluid moving around. We teased it out, had a look at it at the spinal dura and its motion and the activity at the cephalad and caudad ends. All of this we're trying to influence in that Module 1 material, in our Basic 8 Atlas, in our Category 1, in our centering systems. So again, just having a look at a posterior view of what's happening in the cortices and the reciprocal membranes in the skull when all of these pumps are working properly. Cool. So they were our concepts. We also said that your sensory feedback system is paramount and your brain wants to know it's safe out there. So part of what's going on, and if you like, this is where the world of chironeurology has got going, is we're focusing on input from here and of course from your spinal afferents, and as we'll identify shortly from tomorrow from your visceral sensory feedback. Coincidentally, in terms of people with really damaged nervous systems, one of the things that I've noticed in practice in the last 29 years is that stimulating the visceral afferents can be almost as powerful as what we're doing here. Once again, you know, who are you in this picture? Cool. So we're back to TMJ Central. And today we're going to go through the jaw as a protective mechanism. Tomorrow we're going to go through the jaw as a digestive mechanism. So the keys today will be looking at unlocking your defensive system, and we'll with your permission grab some bunnies from our audience just to look at what happens in our standard kind of subluxation or spinal analysis when we unlock the jaw and have done no spinal work. I'm not suggesting we should do that, but I just want to give you a window into its influence. We had this top-down, bottom-up relationship, which we went through in detail. And I hope that everybody's comfortable with that now. And we said that you've got a completely balanced reactive muscle system, welcome, and that it works top down, so that the activity of the muscular system in your head and jaw rules everything below that point. We should wire ourselves from the bottom up as we go from little people to big people, but essentially we work top down, and when our survival responses are enacted, that's when we get imbalance. These are our key relationships. It's been organised bottom up, but I want you to read it top down. And it might be useful for you just to have a feel at the moment where your masseter muscle is, and just feel the tone of that today. So you want to come down, you can't miss masseter, because if you bite hard, it's this big bulk in here. And just have a feel of where masseter is. And then your temporal, kind of temporalis muscle, and just have a feel of how the muscle fans around the suture. So, it's a whole sequence of fans, front, middle and posterior, and we're going to use those concepts as we go through the jaw work. Buccinator, it's a bit harder to feel buccinator, but buccinator's here. And buccinator holds the food bolus in against the teeth when you're chewing. So as soon as you bite down, masseter enacts tone in buccinator, and buccinator pushes the food bolus against the chewers. Now, medial pterygoids, it's easy enough to feel the medial pterygoid insertion, because if you go under the ramus of the mandible, if you wander up even from the symphysis menti and wander up towards the angle of the jaw, you'll hit the medial pterygoid. You can't miss it. You can also access it up here. It's usually, kind of tender, not as exquisitely tender as it can be at the back of the last molar, but nevertheless it's tender. Lateral pterygoid, hard to find. It's at the back of your last molar on the pterygoid process there. So you go up inside the mouth, back of last molar. You can also access it through the open jaw, but be warned, that's kind of more of a pressure situation. It's usually uncomfortable. Some people you're going to run into will say, I don't want your fingers in my mouth. So you need to own up straight away and go, well, the feeling's mutual, and we're going to do this. And we can do it externally, or we can do it internally. If you do it internally, it's usually far more comfortable. If you do a jaw correction externally, it tends to be less comfortable. You can do it that way. I will show you how to do that, because you'll have those sort of people. But ultimately, if you can get inside, it's better. And we know about our splenius capitis muscles. We can't miss this. This is also a window, when we get up to module 4 and we're going over extremities, this is also a window into people walking like this and kids walking like this, or they've got one in and one out. Okay, so if you see, unusual walking patterns, or the duck walkers, or the kids who are walking with the foot in, it's always up here. It's always up here. Splenius capitis is reactive to piriformis. Piriformis turns the leg out when you walk. So often, chiropractically, we'll be working pelvic, lumbar spine, those sort of things to try and influence those patterns. And if you've been in practice for a long time, it's really common. They are injury patterns largely. Often they're birth injuries. But essentially what's going on is you've got hypertonicity up here, and you're going to have hypotonicity down there. And that's why this concept is so important, is to keep that in mind, because heaps of stuff you see in practice, you'll influence just by going, got it. And you can test those things. If your muscle testing's confident, you can test, piriformis, and then you can release the top end and see if it strengthens up. Or if you're looking after sports teams and they've got groin strains, go up the top end and see what's happening and release that and see if it strengthens up. Lots of them will. I mean, sometimes people have both. Patients have stuff. They're entitled to be complicated. Sometimes they've got stuff at the top and stuff at the bottom. But particularly for people who are looking after professional sports teams, this stuff comes into the picture a lot. We went over these concepts of light and dark. I want you to think about and maybe communicate with your practice members, patients, clients, this concept of light and dark. It's not strange. It's just visual input with, lights on and visual input with no lights on. We need both, and we get around just fine with both, and we need to check at least that. Lots of people don't have both, but most people have some of it. And some people may have a pattern that's hard to unlock, where they don't appear to test normally, or it seems like they're all fine. Make sure you check in relation to any traumas that they may have been through. People get through all sorts of stuff and they're stuck. And so we need to sometimes pop a question to their body, if you like, to their, their experiential brain. What about in relation to that? So with people who've had trauma, the scene of the accident, or imagine you're at the accident, if they're willing to go there, sometimes we'll open up what you need to find out. Remember, your body's smart, it's adaptive. A lot of the things we're undoing are your body's attempt to survive trauma. Good. We went through all this. I hope that you've all been starting to assimilate some of or all of Module 1 into practice. And I was speaking to Dr. Matt about what he's doing, and he said, I'm just slowly putting each of the pieces of the puzzle in as we go along, which is awesome. So one of the things you don't want to do is to scare away your existing clientele because you've just changed technique, And for those guys, the older guys, I can see them having a giggle at the back because they've done it. They've walked back into practice, and started to just kind of really completely change practice. When I was a newish graduate, I kind of walked back into my practice after a weekend with Arlen Fur and just went back to doing straight activator. And people were looking at me, well, what are you doing? Well, it's the best thing I can do for you. So I think each unit is a neurological subset, and it's best to do basic 8. And it's best to do cranial injury by itself and 3 and 2 by themselves. But you might find that it takes you a while to get there, and that's fine. As long as you're going through the pieces and you're doing it light and you check it in the dark, then you'll be making great progress. Tomorrow I'll bring in a chart that I've created, which is just a plan. It's an overview of what you could do once you've got Module 1 and Module 2 together, in terms of a care plan. But I just want to show everybody like a visual representation of that, just so that you can start to think about, well, what am I going to do with this in my practice? And how am I going to use this in my practice? I'd like to hear from you in 12 months' time and you're going, my practice is roaring and I'm busier than ever and I'm seeing more people than I ever saw and it's going great. Not the kind of chironeurology concept, which is you're going to see less people. Well, I reckon that's rubbish. If you're doing a great job and you're doing it in a respectful and orderly way, you'll be busier. Great. So that's what we tried to do. We tried to unlock the dura and get your Category 1 functional. We tried to get your centering systems on. Who's having, kind of challenges communicating centering systems to people they're looking after? Okay, so Kim, can you share with us what's happening there, Kim?
Well, it's different to what I've been doing. So when I start adding that in, people are, what are you doing? Why are you doing that? Why are you rubbing this?
Yeah.
So I try to explain to them that it's more about the head controlling the lower back rather than the other areas.
Okay. And how did that go so far?
Okay, all right,
Yeah, cool. Awesome. Well, great work. So I think when you change TAC, you need to identify some simple scripts, if you like, that you can use for people so that they can access the care you're providing and not be, kind of like, oh wow, Dr. Simon's gone right off, he's really out there now, there's no rooms in his practice and it's really gone. Then Dr. O knows the answer to that. So think about what you're going to say. I think the key is, look, all of this module 1 is to ensure that you can centre to gravity. You spend 90% of your energy doing it. You want to make sure that these centering systems, head and pelvis, can actually talk to each other so that your head and your pelvis aren't out of sync. It will influence positively how well people hold their adjustments. And in regards to using the cranial injury complex, it's all about balancing the head on your neck, pretty much. And that's really all people need to know. We're going to centre you. We're going to make sure that your nervous system is coming out of a locked or stuck pattern, and we're going to make sure that your head's balanced on your neck. And then when we go into blocking your pelvis against your skull, we want to make sure that your pelvis is stable, so it can hold up your spine and that your head and pelvis can communicate with each other. Full stop. For most people, that's more than enough information, and you can give them chunks of that information as you go through. Very good. Okay, so what we thought we'd do is, before we get into the jaw, is get someone just to volunteer their body to science. We're lucky we've got a couple of volunteers from the other world coming in this afternoon with funky jaw things going on, so we're going to have a bit of fun with that. But I thought we might just get someone who isn't getting checked very often, who hasn't had a lot of NOT so far, and then we'll just go through and go basic 8, cranial injury, category 3 and 2. And it's, if you volunteer your body to science now, it doesn't mean to say that we won't draw on you later on, but we would like, okay, cool. So come on up. So let's just say, and I'm going to go over this fairly quickly because I'm hearing from our audience that everybody's ready to move on. Okay, let's just make a face at everybody, if you would, to start off with. So when was your last adjustment?
Wednesday.
Okay, and what did you have adjusted on Wednesday?
Diversified, mostly pelvis, thoracics.
Okay, so you got like an innominate adjustment and a
Mostly
posterior thoracic, anterior thoracic.
Yep.
Okay, cool.
Some standard diversified.
Okay, cool. So all right, so we're good. So, I just want to check in as to see what's been done. So we're going to go back and check our patterns. So when we look at him today, other than the fact he's travelled from Victoria, thank you, but what do we see today? What do we see? He's a bit forward. Yeah, exactly. He's definitely a bit forward. He's got this happening. What else? Sorry? Yeah, okay, good. So right shoulder's down. So we obviously didn't get quite right in Melbourne. So let's just test him. Try hold this arm up. And there's a little weak here, so we've got some sort of gait pattern. And what you're going to find as we go through this stuff this weekend is that your gait patterns will come back until all the reasons for the gait pattern to return are gone. So largely that means that until we've got to the end of scoliosis, but there may be other, limbic inputs that are recreating this tendency to pull back in a gait. But he's definitely in gait, and if his centering systems were really working well, then he'd be popping up more than he is at the moment. Good. Jump up on your tummy. Good. Relax there. So first thing we're going to do is we're going to release the heel tension while we're doing that. Because it's an indication that there's some sort of instability in the atlas. First thing. Okay? So there's something happening in the weight-bearing change that means that his system needs to adapt in a certain way to maintain stability, pushing up against gravity. So first thing we do, release one side, release the other side. He's a bit tighter on the left, and we push up. Okay, remember our push up. We're not doing this or that, or we're going to push up and then lift up and let the legs come up, and his right stays short. So we go, well, most likely he's a lateral atlas on the right. Let your head relax. Give it a shake, and that should be enough to clear that. It does. So we'll go on. Category 1, test the hamstring, 45 strong, no problem. 45 on the right, not strong. So if we've got a weakness at this end, so we've found something at this end of the pump, we need to look at the top end of the pump to see if there's a finding to negate that. So I'm going to touch C3 on the right, strong. Okay, that's the one. So I'm going to take that out. Little breath. Good. Then if we've got a C3 in our love-it relationships, we're going to have a L3. We're going to lean on the spinous and transverse and separate them. Huff and a puff. Good. S2, going to release piriformis. So I've just gone on S2 with a pisiform contact on S2. I've covered it. Remember Carl and axiom number 1 from our Module 1 seminar? Never do any work you don't have to do. So we're going to just lean on S2 and just pump it. You can use a drop piece. If you're an SOT background, you can block them category 1 if you want to. I'm going to release it. You could use an activator. I'm going to release piriformis because I'm just going to fall off the sacrum onto piriformis, give it a shake. You could do other stuff. You can, if you've got a footballer or something who needs more work, then I'm going to go neurolymphatic for the muscle, so lymphatic drainage for that muscle, groin and L5, vascular at the parietal end, just touch it. This is a rub, this is a touch, lift at 45. Good. Check it again, hold it, not bad. Okay. So our next step would be, we could check lymphatics because we're already talking about lymphatics. So we've gone tip of coccyx to right K27, lower third of the cord, right side of the brain body. Give it a shake. And if it's on the right side, I'm going to assume that the other one's there. You can test them, but I'll go straight to the right side, and usually with someone who's not getting much work, then I'll go, okay, they need all of them done. Give them a rub. Feel for the induration, use your palpation skills, and umbilicus is for the viscera. Cool. Then we can go into our centering systems, pelvic centering. So I can test him, or you can pop your hands up there. Okay, and it doesn't get much here, so I'm going to go the other side of the brain. Test up here though, eyes open. Okay, let's just check it, little breath. One of the things about functional neurology is the more you know, the more you find out what you don't know. And, you've got to, in practice, just keep it simple. Pragmatise what you need to do. I've just said, okay, well, that side doesn't work. Well, that side did work, but this side doesn't. Just get it done. Little breath. Look, it might correlate with something else the patient's told you in their history or what's going on for them or whatever. But really, at this stage, we're just going to go, well, that hemisphere showed up more than the other one. Back up again. Back up again. Good. Relax that one. We're on this side. And eyes open. Close your eyes. So closure is good. Eyes open is no good. Little breath. Remember our respiratory corrections. I'm just rotating that pelvis in its normal plane of motion. Okay? So we're going little breath. So I'm just rotating medial and superior. And I've got my little frog contact on the occiput medial to the suture, and I'm pushing down towards the nose. So once I've got my vectors, then all I need to do is lean in, which is why I started rocking. People think, I should have a caftan on, or it's all about energy, releasing you. I'm just moving with what needs to happen. Little breath. I mean, obviously I'd like caftans too, and I just haven't introduced it into my practice uniform yet. I'll certainly circulate that on Facebook as soon as I've got it done. Huff and a puff, good. Okay, we'll go back up again. If you're unsure, get them to therapy localise themselves. If you're sure that you're sharp and your testing's sharp and you're not missing anything, great, that's fine. So he's stronger. What else could we have done here? We could have rubbed his visual centres. And we talked about this visual brain last time in regards to you seeing yourself in space, your visual image of yourself in space. And when we get into limbic, you're going to find out how neuroscience has picked this up. Really right back in 2011, but for some reason the chiropractic profession didn't pick it up then. But essentially what's going on is we all create a homeostatic image of ourselves in space. And it's all about keeping things running with the least amount of energy. So we could have rubbed those just to kind of find out, look, is there anything else we need to do? So we've got Atlas, we've done a category 1, we've cleared his lymphatics, and he's now centered head to pelvis, pelvis to head. Okay? So we're clear. Have a lie on your back. So, at this stage, we could either test his hips or go to the universal cranial fold. Okay? So, try tongue left. All right. Who had someone say, that was pretty weird? You know, if you said, stick your tongue out the left, stick your tongue out the right. Okay. So at least 2 or 3. So it's one of the things that you'll get. So just bring it back to earth and go, well, anatomically, your tongue is attached to your throat. Simple lay terms, your throat hangs off the back of your occiput or the back of your head. So we're just using your anatomy to rock this 10 kilogram object on your upper neck, which is like a washer. That's it. That's smart. It's just a functional anatomy test, and that's all it is. It's a functional anatomy test. But until I sat with George Goodhart, he talked me through that. Never heard anybody kind of come up with anything sensible before that. So that's all we're doing. Poke your tongue out left, poke out right. So he only shows on the right, so if he's got a right side, what have we got? Lateral occiput. So we can do a lateral occiput move. Let your head relax. Good. Good. And sometimes you might want to do, you know, just more of a break move on the side, whatever you're comfortable with. Try tongue left. All right. Good. Okay, so relax. And then if we've got a universal cranial fault, we're going to always have our switches. These are our master switches for our lymphatic system. So our K27s, kidney is in Chinese medicine, the basis or the genetic essence of your nervous system. So kidney drives your nervous system. I was talking to, earlier, and he said, oh, if I've got someone in trouble, I stimulate kidney 1. I can't test them, then I'll stimulate kidney 1 because kidney supports nervous system from a Chinese perspective. We'll get to the Chinese perspectives tomorrow. So we're going to give him a bit of rub. Now, what I'm finding with him today, I'd say his lymphatics are a bit congested because I'm having to rub this a bit. And he's been travelling. He worked pretty hard this week, and he kind of fitted a lot in by the look of things. So sometimes that happens. Give it a rub until that induration, that feeling of tension and swelling is done. Then we know he's clear. Good. So the other thing we do is test his hips. Now we could get excited and just say, well, you know, which side does his foot turn out to? Look at that. See this? See how this one turns out, but this one turns right out. So if I tested his piriformis, and then I tested his psoas, hold this up. Okay, so we know there's something going on in pelvis here because we've got a muscle that appears to be strong, but it's reactive pair, so piriformis reacts to psoas. And we know piriformis reacts to splenius capitis. So there's something going on in his network here that says this pelvic system was injured at some time. You're a contact sport guy? Yeah. So we know if you see that, then there's an imbalance there. So we'll just test G medius for his hip stability. Try hold out if you can. Not too bad. Notice the pressure I'm using. I'm not forcing it, I'm just getting him to take the pressure. Try hold out if you can. Okay. Make sure you've got the foot at 90. You've got full control. That's strong, and I don't have to work hard. But this one, I can just lean in. And watch this as I lean in. It gives way straight away. So we know, look, that hip, that femur head is anterior. So we're going to rotate the femur head back up into the socket and give it a shot. Now the other thing that you'll feel as you do that is you'll get a bit of a tone reading on their ITBs. And as soon as you get that tone reading on your ITBs, you know about knee stress. So whether they've got knee pain or not, that's irrelevant. You know, I mean, how many sports people blow up their knees? What did the chiro, I can't remember the chiro who took over AC Milan do to cut all their knee injuries down. He went in, sorted this stuff out, cleared up, popped the tears. I think they cut their knee injuries by about 80%. Bang. Good. Try hold it out now. Reasonable. So we can then check our capsule, iliofemoral ligament, iliotibial band, and see if there's something there. He's got a little bit. You may have to go over this a few times before you get it to lock in. Not too bad. Good. So I'm just stretching it. So I've got my hand on the table side of the greater trochanter, and I'm just trying to get that iliofemoral system to reset. Now he's got a little bit on the right here too. It's very subtle, but it's there. Like if, for example, if we tested this leg here, just push up, just to show, make it obvious. Yeah, it's strong, but what else do you notice? Other than he's got congested lymphatics and he's come from Victoria, that is. Hold up. There's just a little bit of give here. It's just not big, but this is one of the things you want to start tapping into because it's going to save you doing work. As soon as you see that, I go, oh, there's something else here. So I'm going to pop a 2-hand therapy localization we can use for any capsular structure. Try hold it up. Okay, comes up straight away. So if you think you've done the adjustment, the correction right, and then you test again and you get a little waver, then okay, there's something else here. There's something else to sort out. So we're going to go and just unlock that. So I've just gone over the greater trochanter and I'm just locking this up. Good, thank you. And now try hold it up if you can. Okay, try that again. So it's crisper. There's still a little bit there, but it's way crisper. Let's check and see if he's got a gait problem. Shows up, turns out on the right, which would correlate with what we found when we had him standing up. So we're going to check this, eyes open, close your eyes. You know, it's there, it's not strong, but it's there. We could test this way. It's a bit more obvious. We could get him to pop the hands on the eyebrows. You know, so there's a bit there. So if we got 2 coacals in a pelvic finding and 2 ocular or 2 head riding reflexes in the same finding, it says head trauma, pelvic trauma. But if you're playing footy, it's just everybody's got it. It's not some of them, every single kid, which is one of my mantras I'm trying to get across to my local team, is that every single kid has had head trauma and every single kid has had pelvic trauma, and it's got nothing to do with whether they got symptoms today. It's got all to do, everything to do with supporting healthy brain function. That's the key. Little breath. Little breath. So we remember, we're just lifting up the doors of my 1953 Gullwing Mercedes-Benz. Little breath. It's like so. And then I've got the ASIS in my hand and I'm just rotating it down or out laterally and inferior. Little breath. And really the same thing, I can just get over them and lean on them. If I try and do it static, look at this, little breath. Good. Now I can do that, or I can just kind of move with it. And if you move with it, it's less energy. Because really all I'm doing is I'm just putting my weight over them like I was about to do a handstand, really. Promise I won't do that yet. That's tomorrow. Good. Okay, and now he's out of gait. Okay, pop your hands behind your head. So we get flat part of the occiput. We're looking at the visual centers, just recheck it. He comes back a bit. So we're just going to reinforce that. Close your eyes. Okay, we get eyes to your right. Comes back a bit. Eyes to your left. So what are we looking for here? We're looking for centering outside of our immediate visual field. So we're going right at the periphery of our visual field to see if the information front to back is actually being processed accurately. Well, clearly it's not, because as soon as we bring that in, as soon as we bring the extremity of visual field and go to eyes to your right, he'll kick out again and go eyes to your left, kicks out again. So, this is the norm in contact sport. Close your eyes. So he's not your normal person, sorry, but he's normal if you've been playing contact sport. And eyes open. Good. Now we go eyes to your right and eyes to your left. Okay? And we'll use you tomorrow, because when we look at be right there, when we look at limbic input, then we'll start seeing how other things influence our homeostatic visual image of ourself in space. Really kind of key stuff. Matt?
Just in that last correction there, you didn't need to look left or right through that correction in order for that to take place? Or
Yeah, it's just, all you're doing is you're just bringing in the periphery of the visual field in.
that's the challenge.
Yeah.
That's the challenge, we set that off. But
Yep.
then when you made the correction, did he have to look to the right?
No, no, we just, the brain. You could try that if you like this week I had a young boy who's a rugby guy. He'd been knocked out enough that he was, on the ground like this for a minute or so. Not the first time, I'd say. And so this whole area of his visual field was gone. There was nothing there. There was no information coming in from that side. So that's what I did with him was, yes, you could get him to push their eyes out there and then see if it all comes up and, reset for that. So that's in relation to provocation. So you can do the generals, and then you can test a bit further, look here or there, and then you can get them to lock into that. And sometimes you might need to, as George Goodhart would say, body in distortion, you may need to put him into a position where they were traumatised. I remember I was sitting in my car and I was looking out that way and I could see the car coming behind me. Because it's not wrong, it's adaptive. But it's adaptive that's causing us to burn lots of energy. And that energy is moving away from regeneration towards, I'll get through this. So that's the whole key, is that you're starting to liberate energy for that system that they can do something else with that. That's why when you start unlocking kids, they grow. First 2 to 6 weeks, have a growth spurt. Because all the energy, if they're in a distortion pattern, even if their parents have been listening to the clowns from FOSM or any of the other medical or pharmaceutical lobby groups who are telling parents not to get your kids into chiros because they'll get hurt. But those things are keys, particularly for little people. Very good. Okay, so we've got our centering systems nailed. So we did, upper cervical, which was our hemisphericity really, and we did category 1. We centered him at the back, we sent him in the front, reset the hips, made sure the atlas was stable or the occiput was stable. However, the relationship had come unstuck. Lift your head up. We want to go hold your head up. Now, to make it more accurate, we should get the flexors from the arms out of the picture. Now try hold your head up. Now, just to show you when you're testing, lift your head up. He's pretty strong, hold it. Okay, no problem. But you get the flexors out of the picture, try hold your head up, not a chance. So you've got to get all the recruiting out of the way. And the other thing you can do is, if you're unsure, get them to put tone into their extensors. Hold your head down. Now hold your head up. Okay? Because the reactive muscle system will tell you what's going on. So you invoke the opposing part of the chain or the reactive part of the chain and see if there is any relationship there. If there's not, then he'll come up crispy strong. So this is another of our new patients who needs their head stuck back on. So we're going to integrate. So what we're going to tell them is, look, we're going to get the messaging system that helps you balance your head on your neck working. Full stop. Okay, so we're going to, for our purposes, we're going to get our head writing reflexes integrated together. So we're going to go labyrinthine, okay, eyes in the back of your head, to ocular, eyes in the front of your head. So visual information processing, and then balance and centering processing without visual input, if you like, from a functional perspective. We've got eyes open, same contacts. All we're doing, lifting up the frontal bone, got a hold of the occiput, pushing it up towards the nose. Can't miss it, eyes open. Now to start off with, I suggest you do them individually, But if you're repeating, you could probably do 2 together. Close your eyes. While the eyes are closed. And open. Why am I breathing with him? Just help him along the way. We're not having a religious experience. It's not an energy release, although those things may occur. You're welcome to it. We're just trying to get them to breathe in synchrony. Eyes open, tonic neck, close. Then we have to get his vestibular ocular reflex system talking to tonic neck. Okay, so we went head riding, tonic neck, balance the head on the neck, and then we need to get this VOR system, so balance in our ocular reflex system, our processing interface really, talking to tonic neck again. So we're going to go eyes open, to the right, little breath, and left, and up and down, and look to your right, and left, and up and down. And then we're going to get onto tonic neck. I'm going to get a hold of the top 3 cervical lamina and give it a little rub. Okay, and I'm going to go vestibular first. Look to your right, and left, and up and down, and look to your right, and left, and up and down. And the vestibular contact is at the base of the auricular cartilage. It's not on the lobe. You're not telling them off. You're not rubbing motor points. You've just got a hold of the base of the cartilage and you push it down towards the shoulder. It should feel nice, not uncomfortable. It feels nice, right? Or I'll push harder. Okay, so we're going to look to your right, look to your left, look up and look down, look to your right, look to your left, look up and look down. Then we'll do the oculars. Look to your right, look to your left, look up and look down, look to your right, look to your left, look up and look down. So we went head riding, tonic neck, vestibular ocular, and then vestibular ocular to tonic neck. And then we're going to go get that flexion extension motion restored at the junction in the middle of the sphenoid at the sella turcica. Go toes to the nose. Remember we did this last time? Close your eyes, flexion extend the skull, and then stimulate tonic neck. And eyes open. If they can't move their eyes, move their head. It's just introducing motion. Okay? And then what else do we have to do? If we've done a sphenobasilar, we're always going to have a pterygoid. Now, down the track, we could go mouth open, and we could, give it a little rub from the outside type thing. But at this junction, we get to wear one of these horrible things. And we're going to just do it this way. So I'm going to grab tonic neck, relax there, and I'm going to go look to your right, look to your left, look up and down, close your eyes, look to your right, look to your left, look up and down, close your eyes. Now he's wincing a bit because there's not much fun there, correct? Good. Lift your head up and try hold your head up. Now, it's not bad, but if we went hold your head back and then lift up and hold up, it's sort of strong, but I'm just going to go and check. So if I'm looking for the extended part of cranial injury, i.e. the feedback, the sensory feedback from the sutures, I can just go and rub the sutures, just stimulate the proprioceptor fibres and see if he weakens. And he does show, bits and pieces here and there. So I'm just going to spread them, little breath. I'm using this pressure. I'm just spreading gently. In a heavily traumatised skull, you might use a little more pressure. Little breath. Then I'll just give them a rub. Do all the sutures, little breath. Good, little breath. Good, little breath. Little breath. What I try and do is imagine my fingers a suture. And then what I'll do is I'll get pressure on one side and then I'll have pressure on the other side and I'll just gently separate them. Same thing, I'll get some pressure over there and then gently separate it. It's easier than trying to tease everything apart. It's a lot less energy. Then we're going to stimulate centering systems front and back. Excuse me. And eyes open. And eyes closed. And eyes open. Good. Now just lift your head up, and now try hold your head up. Now what we should notice this time is it's crisp. Like the response is, because this cranial injury process, this adaptive process, is invoked with usually rapid onset. So the cerebellus stretch reflex is invoked, and then we're going to lock our head on our body. It's usually something that happens very quickly, and we want to be able to demonstrate that reflex is no longer there. Lift your head up, hold strong, that it's strong. Now, what I'd say with him is, look, we could probably go back over this again, and he's the sort of head where you might, spend a little more time on that process to get it really stable. Because once this is stable, it's a lot easier then to move into our defensive system and unlock that. If this is already balanced, then getting the rest of it unlocked is simpler. If we've only half done this and you try and get into the defensive corrections, you're going to do more work. You're going to do more work, and you're going to do more repeats. So we kind of want to avoid that if you can. So just make sure you get that as solid as you can before you move to the next section. So we've done that. So our next step with him would be category 3 and category 2. So why don't we just go turn over on your tummy. And so we could check him for category 3. So we're going to wake up from S1 up to 10 and see if there's a reaction. So we'll just take him out of program, just make sure he looks all level, looks pretty good. Okay, wake it up. Now, before I test him, I'll just open things up. Look what's happening straight away. So there's something in there for sure. I could do both hemispheres. Something's happening. So, he's had probably physical trauma in his lumbars. Have we got a set of wedges there? Okay, thank you. So he's right short, so I'm going to pop a wedge under the trochanter down towards the knee on this side, under the ASS towards the trochanter on the other side. And then I'm going to move this one down until it gets strong. Okay, and then I'm going to go tap the bone and lift it. Little breath. Cough, cough. We want to see that fifth lumbar pops up and rises. Little breath. Cough, cough. Good. Little breath. Cough, cough. So we had 5, 3 and 1. Seems okay. Check the disc 5, S1. Little breath. Cough, cough. Good. 4 and 5, little breath. Cough, cough. And T12L1 disc shows up. That's, pretty significant. Cough, cough. Good. So if we've got a 5, we're going to have a 1. Little breath. If we had a 3, we're going to have a 3. And if we had a 1, we're going to have a... Come on. I can't work all weekend. So if we look at our love-it relationships, so if we had a L1, what's it going to be? C5. Give it a pump. Rub the riding reflexes, and one of the things we'll notice as soon as we touch his lumbar riding reflexes located on the lamina is that he's hypertonic here. So his back's been injured before, and he'll tell you that he gets back pain sometimes. Yeah, he gets an achy back for sure because he's hypertonic. You can feel the guarding. It's adaptive. I want to resolve that. Good. Check it again. Strong. And, it's all clear. Have a lie on your back. So the next step, we've got a 3. In SOT, 3s are sort of 1s and 2s together. Left hand, left jaw. So I'm telling him, look, we want to make sure now that we've got your head stable and your neck and lots of things working. We want to make sure that your head and pelvis can work together top and bottom working together. Hold strong, not bad, close your eyes. Shows up that way, right hand on the jaw, left hand down. Good. So we're checking left to right for reactivity. And have we got any finger cots? So I recommend you don't use these, just have finger cots. These are way too unattractive. So if we've got a category 2 cranial and we had reactivity on both sides, because the left masseter and temporalis and pterygoids can react to the other side, so we're going to spindle off masseter and temporalis on this side because there'll be tone invoked to protect the skull. We're going to rotate the temporal bone because he had a left category 2, so we're going to have a left PI, if you like, and a right AS, and the reactivity is contralateral. So we'll go a little breath. Good. So I'm rotating those temporal bones, and then I'm going straight in and giving the SI joint analogues, the condylosquamosal mastoidal pivot, the SI joint of the skull, if you like, a little rub. And it's a bit tender. Okay, then I've got the neurolymphatics for the neck flexors extensors, so that's C2 lamina, mid, clavicle slightly inferior, and you'll notice my hands just fit into the slots. Okay? Vascular and rhombus of the jaw. Sphenobasilar, flex the toes to the nose. We just did this. We've got a sphenobasilar, we're going to have a lateral pterygoid. Find the lateral pterygoid at the back of the last molar on that pterygoid process. Give it a shake, it will be tender. Don't go too hard on them. Okay, then we're going to stabilise the sphenoid by lifting or rotating the temporal bone and pushing the maxilla out towards that ear. Little breath. Yep, little breath. Make sure the vector is that way, little breath. My contact is at the level of the first molar. Our contacts through all of the TMJ work where there's a structural correction will be at the level of the first molar. It's always there. Okay, now we can check the stress in his inguinal ligaments. See if there's anything here, nothing. This one shows, look at this, strong. See what happens? As soon as I touch him, we don't need to go, oh, is that weak or strong? Only if he wants me to show it. But I can say, well, there's some stress in your pelvic ligaments here. Look at that. And I can go the other side. Okay, we go right upper. So this is right lower fossa. So it's like, you know, it's like an AS syndrome, an anterior superior nominate syndrome. And we go up to this side, and the PI doesn't really show. So I'm going to just go back to the TMJ muscle activity on the side of that, whichever the nominate involvement was on, because it will be reactive ipsilaterally and contralaterally. But we've already done the contralaterals, and this time around we just had one side that showed up on the issue. Little breath. If you forget it and do both sides, it doesn't matter. We'll let you off on that one. Remember the rotation here, okay? Posterior and anterior, because we had a anterior and a posterior. So with this one we're going to go back, this one we're going forward. Little breath. You can get lost sometimes because our contact is on the mastoid. Pivots, NL, vascular, NL, NV for flexor extensors, sphenobasilar, little breath. Flex the toes to the nose. Much better if you do it this way. You get a lot more movement, you do a lot less work. Good. And mouth open there. Good. And little breath. Stabilise the sphenoid. Same thing. And whoops, I didn't put my wedges in. So, better do that. Hold that thought. Okay, good. So I've just blocked his pelvis for the PI profile, but we're trying to influence this AS side. I'm just moving that block up to ensure that we get it clear. I'm just giving you a bit of a stretch, so I'll just repeat that little breath. Good. Toes to nose. The corrections don't appear this way exactly in your notes. I'm just streamlining it to make it simpler. Mouth open. Little breath. Little breath. Good. And both arms up towards me this way. So what are we checking for here? Psoas. Could be psoas. So we've got a one side is short, right side short. So we're going to flick over the psoas lymphatic, 1 inch, up and out from the umbilicus. Just give it a flick. And he comes up even. So that's all we need to do. So the psoas is a lumbar stabilizer. I'll give that a shake. He'll tell you it's a bit uncomfortable. Both arms up. Now he comes up even. Okay. And so we are complete. Come and have a stand. Good. Just have a little walk on the spot. Good. And make a face, everybody. Now, what do you see this time around? So he's come up. There's still stuff up here. There's still stress in this cervicodorsal junction, but he's definitely popped up. And we're going to have another look at that once we unlock the defensive jaw and the universal jaw or the protective responses and just see how that goes. Thank you very much. Appreciate your volunteering. Very good. Okay. How was that? Comfortable? Any questions that have arisen on your basic 8 corrections? Yes, we're going to do some stretching soon. Steph's volunteered to lead the group. Siobhan's volunteering tomorrow. Any questions? So on any of the corrective processes that we've been through, we did some heel tension, atlas stability. We checked our lymphatics. We checked our centering systems. We checked our hip stability. We checked our atlas and occipital kind of relationships, and our front centering. We had a look at our centering affected by peripheral inflammation. We cleared out the cranial injury complex and made a note that we might want to come back to that with him again. And then we checked category 3 and category 2 and knocked those things out as well. That's module 1. So there's quite a bit there, but you can also see that you can do basic 8 in 5 minutes just like that once you get to that level. We don't expect you to do it yesterday, but once you get the hang of what you're trying to do and where you're trying to go with it, it's really quick because you can just go, great, basic 8 and any of my subluxation analysis that I want to introduce into this process, you can just dovetail them both together. Go.
Simon, on the category 2, where you rotate the mastoid,
Yes.
like that, how did you see which way was going to be?
Cool, because he was a left. If it therapy localizes to the left jaw, then he's going to be a left category 2, which means he'll have a left. That the pelvic system, if it's involved, if he has a, yeah. So if that didn't show, then sometimes they might have a right side pattern, which would be the reverse pattern, and we'd have a right posterior nominate, left anterior nominate down here.
So when it was on the left side,
Yeah.
was that left down, right up?
Good question. So basically, what we're saying is, if it TL's the left side, then the craniosacral relationships will be left PI to left posterior temporal bone. Okay, because we're resetting the body pelvis to the cranial pelvis. So body pelvis components, 2 innominates, sacrum in the middle, coccyx on the base. Cranial pelvis components, 2 temporal bones, if you like, cranial innominates. Occiput, sacrum, sphenoid, coccyx. So if we're here, down here, then we'll have the same pattern contralaterally in the cranial system on the opposite side. So we're going to have a left posterior temporal bone, okay, and a right anterior. We're going to pull those out of that pattern. So that's a key, is that we've got a cranial pelvis made up of the temporal bones, occiput and the sphenoid, and that rules our body pelvis. Okay? And you may want to have that conversation with patients, clients, practice members who are interested. Well, this system here holds your head up. And this system here has priority over this one. So if we're going to get this working really well and have a better chance of keeping it there, then we've got to get the two systems working together. So the key is, and we showed you a video last time in Module 1, and we had Dr. Frary going through the cranial pelvis and body pelvis, and you know, there was stuff in the light and eyes closed and whatever. So you can, that's really relevant, but I think what we want to do to begin with is, a lot of you people are going to have, you know, body pelvis category 2s. And if they got that, they always will have a cranial 2 pelvis as well. Sometimes when you've got infants or little people, they might only show a cranial 2 pelvis. So you do the cranial correction, but you don't have to do the pelvic correction. So neonatal trauma, you know, where that's the norm, that they'll have a cranial category 2. And there may be other cranials we need to do with that age group, and I know that all of you, there are lots of people here with different skill bases in that neonatal cranial zone. But I want you just to think about it. Cranial pelvis, body pelvis. Cranial pelvis rules body pelvis. Most likely, lots of people you see will have both, and you'll be doing what we just did then. And, you know, but not always. And we need to check them eyes open, eyes closed, in the light and in the dark, and in relation to the trauma. So with you, we might go back to that situation when you were concussed or stunned or whatever, and there'll be a few that might come to mind. And you'll find that once you start unlocking these patterns for people, they do come to mind. Because you ask them in their consult, have you ever had a car accident and been knocked down? No, fine. You ever ridden horses? Oh yeah, I rode horses. You know, and you start their corrective process and you go, yeah, hey, look, it came back to me. I was knocked out. So, they're the keys, and that's Module 1. Who's heard about sympathetic dominance? Yeah. So, I mean, you know, it's almost like, and I know Wayne and Angela well, and I think it's great that that protocol's out there in, you know, in terms of bringing us into thinking about autonomic function, because you've got 3 autonomics really. You've got sympathetic, the go fast fighting machine, you know, get things done, deal with the alarms and the challenges, and our go slow machine, which helps us to, you know, assimilate nutrients and slow things down and stay with our survival systems when we need to turn them on. And we've got our third arm, which we'll talk about tomorrow, which is our enteric nervous system, which is now kind of considered the third part of our autonomic machine. And the exciting thing about the enteric nervous system is it's actually an extension, really, of your limbic brain. They're interactive states, they grow from the same tissue. And so it's a whole connected unit that I think before we got into this world of neuroplasticity, that, you know, people couldn't understand what chiropractors had been talking about for 100 years. They still don't get it, but we'll keep telling them. Great. So when we get challenged physically, when we get challenged emotionally, mentally, and when we get challenged biochemically, by, you know, something that's toxic, or we're unwell, or our body's trying to get rid of a bug that, you know, means we have to raise our temperature, we involuntarily invoke a defensive response. And the first thing that we do is we want to make sure that when we've got a defensive response going on, that we can maintain the health of our central processing unit. And the central processing unit lives in here, and of course we haven't got a spinal column, but in your spinal column. So that's the hard bit on the outside, and inside we've got that tough tissue, the tough mother, the dura mater, stronger than 10 tigers, stronger than tensile steel in its longitudinal axis, no stretch fibres in its longitudinal axis, designed to protect the central processing unit. Weak point is your temporal bone. Temporal bone's got a beveled edge, so that cranial suture does, move, they all move, but this is compliance. This is sort of like, getting a bit of plywood and bending it, whereas the temporal bone is real motion. And the temporal bone is the thinnest part of the skull, and the temporal bone is the most sensitive and therefore the most dangerous spot to receive impact. So the first thing that we do when our nervous system is challenged, it doesn't matter what challenge it is, it's an involuntary response. I guarantee you that we can test all of you today and do something to you that challenges you, and you'll turn it on. The turn on is this thing, the mandible. The mandible's a horseshoe, and the horseshoe's there to lock the skull. And as soon as the mandible engages, obviously this guy's been to the wrong dentist. There we are. As soon as the mandible engages, pushes up into the temporal bone, and the skull begins to lock. So it locks mechanically, it locks externally through the function of masseter and temporalis, and it locks internally as the pterygoid muscles get to work on the sphenoid. So the structure locks externally, and internally the dural system locks at the top through the action of the sphenoid, pulling, through the action of the temporal bones, the pterygoid muscles, pulling on the greater wings of the sphenoid. And at the other end, the levator ani muscle and pubococcygeus lock the dural insertion into the coccyx. So both ends lock instantaneously. Now if you deal with the challenge, then you'll let it go. But what happens most of the time for us is that for some reason that challenge isn't resolved. The trauma, you didn't get to move or move through it, or you just knocked out and you were kind of locked in time. So what often happens is that dural system is locked internally, and your osseous housing is locked externally. So our next section is to unlock the housing and to unlock the tension or the engagement of the dura mater at the top end, and also at the caudate end, where the filum terminale, the end of the system, ends up in the coccyx. The other thing to keep in mind is that we've got this mechanism inside, okay, this meningeal system inside, and there's a connective tissue bridge up in your upper cervical complex between the dura mater and the cervical fascia. Okay? Everybody said it was rubbish, and then the anatomist teased it out. It's in Gray's Anatomy. And Chapman Smith, when he was doing his reports, made a big thing about this, because the cervical fascia runs along the margins of the clavicles and along the superior margin of the scapula posteriorly. And so it's like a sleeve. So when the dural system and when the cranial system goes into defence and you've got increased dural tension or activation of the dural system, you're going to have activation of the cervical fascia. And that's going to influence how well your spinal system holds, how neutral it is, what's going on in your extremities, particularly in your shoulder blades, so the motion of the scapula. And I was very lucky to have an adjustment with Dr. Feldman yesterday, and there's a whole protocol in activated methods, and we'll certainly bring you into the NOT extremity conversation in Module 4 about what happens when this cranial pelvis starts to influence what's happening in the thoracic pelvis as well as the body pelvis. But for the purpose of our conversation today, we're going to talk about the horseshoe, the mandible locking the skull, and we're going to talk about what happens internally in the dura, at the top end, and at the chordate insertion to unlock that. And then what that does is to bring us out of sympathetic dominance. Now, if we've been in sympathetic dominance for a while and the alarms have been on and the endocrines have been, changing and our blood pressure's up and all sorts of peripheral changes are going on, what's likely to happen? What's likely to happen if we've been in sympathetic dominance for a while? What do people say? What's one of the most common things people say to you when they come in? Other than good afternoon or what's it cost today? What do they say? I'm tired. Feeling tired. My energy's down. Because we know that through our HPA, our hypothalamic, pituitary, adrenal axis, that there's an array of stress responses that get enacted. Now, if they're turned on and turned on and turned on for years on end, then you're going to be depleted. You're going to go back into our three-brain model and we're going to go, okay, well, if the sympathetic alarm system's turned on, our fight-flight responses are turned on, what happens to the digestion and our endocrines? You have to turn them down. So the thing you'll find with most people, if they're in this mode, and you'll find lots of people in this mode, is they're depleted. It's not that they're not eating food. Sometimes they're not. Sometimes, they just don't watch enough television. That's how we get to know how to eat the right sort of food now. So when we unlock this, you might have a look or consider those other things, because next time in Module 3, we're going to look at endocrine and getting those things turned on. And what we're going to do tomorrow is, once we've unlocked defence, we're going to get that immune and digestive system fired up again so that we can start assimilating nutrients and we start getting that part of our survival brain, if you like, and our survival body operational. Cool. Okay so far? Yeah. Very good. So, where's my little shooter? Here it is. So we've got I think we've got a little video to show you.
If you're a normal mammal, what stress is about is 3 minutes of screaming terror on the savannah, after which it's either over with or you're over with.
For a few weeks every year or so, Sapolsky shifts his lab to a place more than 9,000 miles away on the plains of the Masai Mara Reserve in Kenya, East Africa.
You live in a place like this, you're a baboon, and you only have to spend about 3 hours a day getting your calories. And if you only have to work 3 hours a day, you got 9 hours of free time every day to devote to making somebody else just miserable. They're not being stressed by lions chasing them all the time. They're being stressed by each other. They're being stressed by social and psychological tumult invented by their own species. They're a perfect model for westernized stress-related disease. Because what stress is about is somebody is very intent on eating you, or you are very intent on eating somebody, and there's an immediate crisis going on.
When you run for your life, basics are all that matter. Lungs work overtime to pump mammoth quantities of oxygen into the bloodstream. The heart races to pump that oxygen throughout the body, so muscles respond instantly.
You need your blood pressure up to deliver that energy. You need to turn off anything that's not essential. Growth, reproduction, you're running for your life. This is no time to ovulate. Tissue repair, all that sort of thing. Do it later if there is a later.
When the zebra escapes, its stress response shuts down. But human beings can't seem to find their off switch.
we turn on the exact same stress response for purely psychological states, thinking about the ozone layer, the taxes coming up, mortality, 30-year mortgages. We turn on the same stress response, and the key difference there is we're not doing it for a real physiological reason, and we're doing it non-stop. After a while, the stress response is more damaging than the stressor itself, because the stressor is some psychological nonsense that you're falling for. No zebra on earth running for its life would understand why fear of speaking in public would cause you to secrete the same hormones that it's doing at that point to save its life.
So the other thing that happens is that you're going to go back to level 1 brain function. You're not at really limbic. The sensation and the processing of the danger or the signalling that's coming in, you know, about the 30-year mortgage or the viral infection or the toxic overload, it may be initiated there, but you're going to go back into your survival brain. And that's why we see a whole bunch of stuff, you know, that we don't want show up. This is the norm, as Sapolsky was talking about there, this is the norm in modern society. And that's what we can do, and that's what we are doing, and however you're practicing, that's what you're already doing. But what we're going to show you today is just a bit more on purpose. We're going to show you on purpose, unlock this defence system, unlock the sympathetic dominance profile, in conjunction with all the other work you're already doing. But that's what we want to do, is to get the system out of that mode and move that activation, that sensory activation, back to cortical. Cool. Very good. Okay, so far, was that helpful? Just to have a little think about, you know, sympathetic dominance and stress response and how things go. Very good. Here's our universal jaw. We talked about that. It's your protective lock. Just have a feel of your temporal bones there. And you can't miss them, you know, because they're right on the side of the head there. You can go in here, you're on the lateral wings of the sphenoid, and just have a feel of them, and just feel like what happens when you bite down. Okay? Good. Then just have a little feel of what's happening down here in your pelvic system, sacral system, and then bite down again. And feel that lock, feel that tension come on. So we do it all the time. And most of us today would have had this week. Sometimes you resolve it yourself, but very often you don't. And if you don't resolve it, then we know from our organisation process that if this system's turned on, then we're going to be turned down here. And that our abdominal system is supported by a bunch of tissues. And one of the things that we don't like to see, or we all get concerned about or say that we should get rid of, is that, you know, the pendulous abdomen, the abdominal ptosis. Welcome, Sandra. Nice to see you. Thanks for coming. So that's what we're going to unlock straight away. So we're going to unlock this universal jaw pattern. And when we do so, we can start to restore tone here. But of course, as soon as this chain moves into activation, we're going to see changes in our abdominal diaphragm tone and our urogenital diaphragm tone, and we're going to see potential breakdowns in our respiratory system or our respiratory efficiency, and also changes in the junction between our digestive system and our thorax. So universal jaw is a window into all of those kind of common things like hiatus hernias and you know, other maladies or issues with ptosis of abdominal organs, or chronic valve issues, or reflux issues, reflux down here or reflux up here. The key is, once again, to think about what happens when your universal jaw is turned on. Is that as soon as this locks, we're going to see changes in our abdominal, urogenital, and our diaphragmatic function. So that's what happens. We get persistent imbalance in the core, And when we get persistent imbalance in those things, we know that that's going to contribute to back pain. Who does rehab in their practice here? You know, like physical rehab, exercises and stuff like that. So I had a rehab centre a long time ago, before there was Pilates and for all those things. It's a very expensive process. And we had all sorts of techniques going on. You know, we had Eastern European physiotherapy techniques run by the chiros. We had standard physio, we had Feldenkrais, you name it. But what we found was that if you don't unlock this system, the involuntary protective responses, then good luck in getting your voluntary rehabilitation and toning underway. So basically what I'm saying is, if you don't unlock this stuff, then your voluntary rehabilitation will never be as effective, because all you need to do is get yourself in a position where you've invoked this challenge, and all of that good work you've done, all that toning you've done, really doesn't count for much. So once again, this is something you'll see a lot. I see it a lot more in practice than I used to 10 years ago. People do lots of rehab stuff, lots of exercises, Pilates and yoga class and all sorts of stuff, which is great. I mean, you know, people are moving towards a higher level of fitness. The only issue is that largely their involuntary systems are not dealt with. And so they're like little time bombs with tone on the outside. They might look better on the outside. I'm sure that lots of things happen when their tone increases, including their brain chemistry, you know, positive changes, etc., but they don't hold. And the same goes for the other end of the spectrum, where you've got professional athletes who've had head trauma. They're at high risk of their unstable systems breaking down. And often the window into instability is not, oh look, I've got reflux, or you know, I've got abdominal distension. What happens is we see it further down the chain in the knees and ankles, particularly in sports people, because that's what happened. As soon as you destabilise this, everything here runs with the equation, and the most common injuries are in these areas. And it's all about stability. And they haven't got stability in their pelvis, and they haven't got stability in their head and neck and jaw, and so all of this stuff's at risk. So it's a good thing to keep in mind, because you see it all the time in practice. I'm seeing my physio, I'm doing my rehab. You know, if I just do my rehab, I'll be okay. Particularly for new people coming into chiropractic care or neural organisation technique care. A lot of them are seeing other people and they're doing rehabilitation. And the issue at hand is it's a temporary fix. It's not going to change everything. I'm not suggesting that it doesn't help, it does. But it works way better if you get the involuntary stuff sorted out first. Because a lot of these back pain issues kind of come from this imbalance. So obviously this is a patient who didn't pay their account, and so we did some chiropractic bloodless surgery and took them apart. When you're looking at universal jaw, it's a really simple test. We're just going to pop a bilateral contact on the masseter and test for it. Now, if it's just mandible involvement, and you'll see it in little people, it is often just mandible involvement, then thanks for laughing at my jokes too, I appreciate it. You're on, you can stay. Then all we're going to do is release the mandible. We're going to take the tension out of the horseshoe, and you'll feel this. When you get into someone's mandible, you'll notice the ones where it's been really tight for a long period of time, or there's a lot of stress because the horseshoe has narrowed. And it's relevant too for those of you who see children, particularly when they've had or they're getting recommended orthodontic or other jaw therapies to widen their dental arch. You know what I'm talking about there, that space that's the mandible and the space that's the maxilla called the dental arch. So there's a lot of therapy going on out there with kids to widen the dental arch. Some of it's inspired, but a lot of it, particularly orthodontics of 15 or 20 years ago in Australia, messes up lots of kids' jaws. And of course the carrying angle of the mandible is around about C2. So the mechanical axis that you influence when the jaw is unstable is at about C2. And so those people, when they've had their teeth pulled out and that dental arch has not been spread or widened first, often become very good customers because their head and neck is basically unstable all the time. So a good thing to keep in mind, particularly when you're checking kids, I really recommend that people check kids. You know, they're the ones that we make the biggest impact on, I think. But one of the things you want to look at is what's the feel of that dental arch like? Do they need some assistance to spread the arch, as well from a developmental perspective? Because if they've got respiratory compromise and they're mouth breathing, quite often those arches haven't expanded normally. So when we check them, we're going to open it up, and then when we get inside, we're going to look and see, well, what's the tension level like in here? And what's it like up here? Now, often this is way more tight than maxilla, but nevertheless, review it, because after a while, you'll get a feel for, well, look, how much is this messing up this body? Good-o. So, two parts, condyles only, that is the mandible jamming the system and getting that skull ready for impact, part one. Part two is the whole jaw system, the two dental arches, that's the maxilla as an extension of the cranial pelvis and the mandible tightening together and locking. And when we've got the maxillary involvement, this is when we've got more instability in our caudad neuromuscular stability. So when we've got the maxillary involvement, that's when we need to go looking to see what's happening in the diaphragm, what's happening in the urogenital diaphragm, have we got any chronic instability associated with this pattern. There's a story here. Who sees bedwetters? Who's wet their bed lately? I know it sounds funny, but I've got a friend of mine who's a urologist who has volunteered that on a number of occasions that he wets his bed. So, you can see this a lot in our technology. We've always kind of focused on sacral function. In most techniques, we'll look at that. Absolutely, that's important. But you'll find that if we unlock this mandible and we release the maxilla and we get this system here, this neuromuscular system here responding normally, then that is, it's got sensory feedback and motor control, you'll have far better outcome. Very good. Okay, so far. This is really simple. The ramifications are really significant, but the process is simple. So what we're going to do is, Mark, we might get you back to science. And then, so what we'll do is just show you with Mark the two pieces of this universal jaw, and then we're going to play shot that straight away, and we're going to kind of run a tighter shop around that. And we'll just get, someone's lost their head, jump up on your back. As long as it's not me. Cool. So, just both hands on the jaw. And we're going to test it, and he shows up weak. So just to show you what's going on, and sometimes you might need to talk to your people as you're transitioning a new technique, and you're going to go, well, your brain works top down, and if there's anything up here that's engaged that shouldn't be, then what's happening down here may not be working. So this system turned on, this will be turned off. Let's just have a look at that. So we test the hip, hold out, strong, both hands on the jaw, hold out, no good. Now we could then go ahead and go pop your thumbs on the roof of the mouth, and make sure they're at the level of the first molar, and just give it a spread and see if the second part's there. And he's lucky he's got both. So lots of adults you'll find will have both. So what we'll do is spread his mandible and then we'll unlock the condyles. And when we unlock the condyles, we can use a gentle manual technique. You could use an activator, down like so. We could, use a double thumb. I like to just use a thenar contact and give it a release. So we'll go mouth open, level of the first molar. Spread it laterally, little breath. And feel for motion. Now he's not too bad. There's restriction here, but it's not bad. My hand can move easily now. Then I'm going to come up, unlock the condyles. We could, you know, like so, I could get my activator wound back to the first notch, give it a release, mouth open now, thank you. And then we're going up to maxilla, little breath. Good. Now, what we'll show with the maxilla is if that's involved, and we proved that it was, then there'll be some adaptive change in our centering. It's often, you know, what we call a left homolateral gait, but I'm just going to rub both of them, so head riding and pelvic centering. And K27, little breath. Little breath. And then, so we've freed up the mandible, we've spread the maxilla. Whenever that happens, there's something changing in our centering. So we can go test it out if you want to. You can test that out, or you can just rub those things. The next thing that'll show up is some sort of change in our switches or our lymphatic system. And we're going to spread the maxilla again. Usually when we've got this pattern, there'll be a parietal descent. So the parietal bones will be in descent. We're just going to lift them, and we're going to lift them by crossing our thumbs across the sagittal suture, grabbing a hold of the parietal bones and lifting up. Little breath. So I'm just across the sagittal suture, and then my fingers are over the parietal bones and I'm lifting. Little breath. Whenever there's a parietal involvement, there's always going to be a gallbladder involvement, so we're just going to put my finger on Murphy's point. Everybody knows what Murphy's point is, the gallbladder reflex. So we're just going to grab hold of that as a kind of biomarker, and then just give that a little rub and stimulation. We're going to use a reflex point on the TS line, the temporosphenoidal line, that relates to gallbladder, and we're going to go through this tomorrow. But for now, just stay with what we're doing, give it a rub. And then we're going to come up here and we're going to test and see, well, what's our pelvic floor look like? So we're going to go squeeze the knees together hard as you can, hard as you can. Now, you know, he's a sports guy, you know, so he's pretty strong, you know, and just squeeze your knees as hard as you can. Okay. Now he's got big muscles here and I've got little arms. So this is fairly, you know, weak. Squeeze as hard as you can. Squeeze, 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 squeeze. Keep going. Squeeze, squeeze, squeeze. Keep going, keep going. Squash, squash, squash. Okay, relax. Push out and then push in. Now you may have to get some of the reactive chain involved here to get this to turn on again. Squeeze here, hard as you can. Good, but that's better now. So we're going to push up, and we're going to stimulate that perineal reflex to get that urogenital diaphragm to start to go back to normal tone. Little breath. When you're pushing on that, sometimes you may wish to skip this step if you really feel like the patient is like, oh, I feel really uncomfortable about that. In your notes it says to use a thumb. Never do that. It's always use a knuckle, because the perineum is a very small space, and the thumb can go astray. So I recommend you don't do that. Little breath. It's not part of my fee schedule. So once we've turned that on, then we just need to get the respiratory diaphragm stimulated. Okay. And tuck those fibres into the pelvis, both hands on the jaw, and check it now. Cool. So, thank you very much. We might just get one other person up just to show you that process. Sorry? Okay, if you want, sure. And Kim, we'll have you. We'll grab you for science. Don't you worry. Just nose down. So with what we're going to do, because we're going into universal jaw, he hasn't had anything checked today, so we just check his patterns. So we're going to just quickly buzz over and check Atlas, Category 1, cranial injury, because we want cranial injury clear, because we don't want to go into defence until we've got this stable. Otherwise, we're just kind of fighting ourselves and creating work. So he's okay there. We'll check there. So he shows a bit on, you know, the inferior occiput bilaterally. So we test on the left side. The first thing, if you get a left side hamstring TL, go straight to the occiput and see if that's what it is. It could be a left category 1, but most of the time category 1s on the left will swing back to the right. So the law of averages in terms of cutting down, mucking around, is identify, is that there, check the occiput. If it localises and says, yep, that's the one, then just do that. If you go up here and there's no change, then you could go over to C3 or C23 on the left side. Are we okay with that? Yep. So it's a kind of, I'm starting to create just a little bit of shortcutting, but it's just so we don't muck around. I'm giving you common scenarios. Right, here we go. So we're going to go inferior occiput, let your head relax. Good, thank you. And I'm just going to drop in on him there. S1. Okay, we'll clear it out. Now try hold strong. He's good. Now if we've got that, hold it. It might swing back to the right now because there could be a category 1. If you got this, you know, posterior sacrum, inferior occiput, as soon as we clear that, you'll probably show up in a category 1. You may not always, but you probably will. He does. Because as soon as we go, he goes right short, right weak, and then it strengthens to the C3 on the, you okay with that? Yeah, cool. So we go, little breath. I relax there. Little breath. And good. We'll just check his lymphatics. He's been travelling, so we'll just check the right side. If I've got a right side to start off with new people, I'm probably just going to go through all of them. I could check each one, but I'm just going to go through all of them. Check his centering. He's okay there. You a sweet tooth?
Not usually.
Not usually. Had a cold?
Yes.
Yeah. Okay, so there's a limbic thing we'll use him for tomorrow. Have a lie on your back. Okay, so we could check his hips, so we could test G medius and G minimus, or we could just kind of localise the bone on each side and give it a nudge. So I'm introducing a shortcut you haven't seen before. So we've just checked the bone on so left femur head showed up anterior, and then I was checking the iliofemoral on that side as well. Okay, so that's all good. We'll just check his centering. Just bring him into the picture. It's pretty good. Eyes to your right, eyes to your left. So he shows up a bit front to back and back to front, so we're just going to reset those. And he's had head trauma. So we know that we might do a few go-rounds with him on each bit to get it to clear. It's good to have an expectation of what to look for, because I think you can, we could do, you could get an impression that if we did cranial injury once, it's fixed. Well, the reality is you'll probably do it a few times before it locks in. I want you to try and get it locked in every time, but you'll probably do it a few times. So we're going to just check his cranial injury. Hold it up. He's not bad. Okay, so we could get him to pop his hand, relax back, arms back, and just lift your head up. Try hold your head up. So he does show still some weakness. So we go back and do cranial injury. So we go head riding reflexes, eyes open. Close your eyes. And open. Tonic neck, top 3 cervical lamina. Eyes open, close, open. Look to your right. Left. Up and down. Vestibular ocular reflex system. Look to your right. Left. Up and down. VOR to tonic neck. Look to your right. Left. Down. Look to your right. Left. Down. Look to your right. Left. Down. Little breath. Close your eyes. Good. Thank you. And we need to go tonic neck to lateral pterygoid. So go look to your right, look to your left, look up and look down, close your eyes. And look to your right, look to your left, look up and down, close your eyes. Good. Lifting your head up, try hold it up. It's not crisp, it's not bad, but it's not crisp. So we'll just challenge those sutures, just rub the fibres. Okay so far? I know it's a bit tedious, this bit. It's sort of the upskill zone, so little breath. Now the other thing we see with Dr. Feldman, as soon as I move his head, you know, we can feel that it doesn't all move all that well. So I'm suspicious that he's got dural tension because, you know, he's been a chiro for a long time. So I know that he's had his alignment checked a lot. And I know that, relax there, everybody's chiropractor is better than everybody else's. But nevertheless, I assume that he's had his system checked by competent people. So we know, look, the alignment's been looked at a lot, but maybe what hasn't been looked at with him is this dural tension. Just lift your head up, hold it, strong, good. So if we were moving on to universal jaw, we go both hands on the jaw, yeah, and just to get him to have a feel of this, we'd go hold your leg out, straight leg, and hold it out, good. And then both hands on the jaw, and hold it out. And straight away we can see, look, it just comes unstuck really, really quickly. So we could spread the maxilla to see if the secondary component is there, i.e. is there a skull lock in the mandible, or have we got mandible and maxilla and then all of the reactive muscle chain as well. Or, so I could spread up here, to test that I could just cross the K27, cross from right to left and hold him up this way as a little, you know, kind of simple, quick way of identifying, is it there? So we're going to go mouth open, we're going to go first molar, little breath. Once again, he's not too bad. You can see, if you're close enough, you can see my hand and is moving. So I'm going to just release the mandible, the imbrication, first molar spread of the maxilla, reset the centering. K27 will show up, little breath. Parietal bone correction, little breath. Once the parietal's clear, we'll see a gallbladder reflex. Now often this is not tender until you've done the correction. As soon as you do it, bring that sensory feedback to the surface, their awareness of what's going on changes. Most of what's going on for all of us most of the time is completely, you know, we're completely unaware of it until we bring it to the surface. Bend the knees up, check the pelvic floor. Now he's a super strong guy. He works out like 3 hours a day, he told me. So, you know, if I worked out 3 hours a day, I'd be big like him. Okay, squeeze the knees hard as you can. Now he can sort of do it, and he's really, really determined. He's a determined guy. Squeeze out hard as you can. But I can still break him. Now someone of his strength, I should be really not being able to move this. Push out. Good. Look at him push out. Push out. Okay, you see the strength there? Now push in. It's still not there though. So we're going to get him to work it. Push. Dr. Maz, how you doing? Hard as you can. Squash, 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 squash. Keep going, keep going, keep going. Look at this. See how it's not turning on? So we know, for example, if we tested his diaphragm or have a sit for me or tested his abdominal system, it probably wouldn't hold at the moment. Squeeze there. And if we extended down from that and tested his hips, same, knees, same, etc. So we've got a reactive muscle chain in a very strong individual that has been turned down. Squeeze hard as you can. You'll win this, don't you worry, you'll win. Squeeze, squeeze from New York, so he likes to win. Squeeze, squeeze, squeeze. Squeeze, 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 keep going. Squeeze, 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 keep going. Still not there. So we're going to push out again. We're going to invoke the reactive muscle chain. Squeeze out, push out, don't worry about me. Good. And then we're going to squash in. Keep going. Now you notice how this is starting to change. But his was really, 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 really turned off. And then we're going to go get the urogenital diaphragm, just put some tone back in there, little breath, little breath. We'll give it a little flip, take a breath, and at CB3. And then we're going to push the diaphragm back under the ribs. Of course, we'll be influencing psoas and other muscle systems at the same time. Push the muscle fibers back into the pelvic girdle. Okay, he looks worried. And now we'll just test his abdominals. Now come up and now try to hold yourself up. Okay. Now that's not on completely yet, but he's starting to turn on. And that's what I wanted to show you, but particularly for people who are gym rehab people that underneath their apparent stability is very obvious instability, and that's what we can reset. Thank you, sir. Very good. Good. Okay.
Gordon, can you just go over the perineal punch?
Yep. Yep.
Explaining that to the patient.
Yep. Yeah, cool. So, you're welcome.
I just thank you. I just want to say every time I come off that table, I'm like,
Better, clearer, good.
I feel really good.
Yeah, good, awesome. Thanks for sharing that with us. Thank you. So Julie was just saying, imagine if we had a camera down here. Just hold yourself back. And well, the room's out of control already. And that was my perineal tissue here. Might be about that space. And what we need to do to invoke that perineal reflex is to rapidly push up on it this way so that we get a bit of stretch in the tissue and the reflex kicks in, and then we should see that the urogenital diaphragm pushes up. What we need to watch out for, because in your notes will say use a thumb, is I think using a thumb when you're not particularly skilled at identifying that area is problematic. So what I'm suggesting you do is you use the first, kind of the obvious knuckle on your thumb, because it sits in there easily. Okay? And really that contact, because it's hanging off this big thing called your hand, it can't go anywhere. So you can't lose it. This thing could be lost somewhere. Been there, done that. Not that good. Avoid it. So we're going to use just the prominent knuckle on your thumb to invoke the reflex. And when we invoke the reflex, I'm swapping to the other hand. This is my perineal area. I want to just give it a bit of a shot. Now, usually, to make that more powerful, we want them to breathe in and breathe out. And as they breathe out and the pressure's coming down their abdominal cavity, push up against it. Okay. Usually, it's not a problem. I will say to people, when you have this pattern, your abdominal tone and the way you hold up your abdominal organs is down. We want to make sure that tone comes up so that you lift appropriately. Everybody wants to be nice and strong and toned there. So it's going to put some tone back into your abdominal system and make sure you're lifting properly. Is that okay? Ask them, is that okay if we do that? And just they'll say, well, what are you going to do to me? I'm going to go, well, I'm going to just gently push up on this as you breathe out, just to put a little stretch reflex in there. Is that all right? Now, if they say no, leave it. Come back to it another time. But generally speaking, there's just not a problem with that. But I emphasise, don't do that unless you really know what you're doing. You're going to use the prominent knuckle on your thumb, which just works fine.
Are we trying to contact a very small spot on the patient?
While you're in, you can't miss it really, because you want to get up into the perineal tissue. It's a very small space, and if you go forward, there's all sorts of trouble, and if you go back, there's all sorts of trouble. And when their legs are at 45, that small space is exposed. And really, it's right in line with your contact. You can't miss it. What I want you to do in play shopping today is get a feel for what it feels like on you, And we've got a volunteer at the back there. I can see that, great. It's probably the most sensitive correction in all of our protocols that we're going to teach you. Thank you, Dr. Russell Clark. And it's also where you need to be most sensitive and sensible and ask for permission. Is it okay to restore tone to that, which is going to put some pressure on your pelvic floor? Most postpartum women just, they're kind of used to having stuff done. They're just fine. But younger women particularly may not be. And you just need to make sure that things are going on. Now, in younger women, they often have more discomfort here because this hasn't all been stretched out. And younger women may have ptosis in their abdominal cavity, and the uterus may be sitting one way or the other. It may have dropped down. They might be saying, look, I'm really embarrassed, but I'm having a lot of pain after sex with my partner. And so all these sort of things come to the surface relating to loss of tone in their abdominal area, particularly the lower abdominal viscera. So it's something that you will find is really important in younger people. Certainly in the bedwetters, etc., you'll find it very important. Once you've done that perineal punch, you want to just put some stretch into the abdominal cavity. So you're going to go just above the pubis and get them to breathe out and flick up. If we're looking at the uterus dropping down one way or the other, it's rarely symmetrical. Just like pelvic rotation is rarely symmetrical. There'll be one side that's more down than the other. And so you might need to come down and give it a lift up. We're not trying to break adhesions, be warned. We're not trying to break adhesions. We're just restoring normal anatomical relationships. Okay, and you will change a lot of positional discomfort. So it shows up a lot in dysmenorrhea. It shows up a lot in postpartum women as well, where things have been stretched a lot, often for the first time, and often the pubic symphysis hasn't been reset because you did all your module 1 work, you've got that nailed, and also that some of the abdominal viscera may be in relative ptosis. It's drooping down on one side or the other, and you may need to go in just gently and lift up. So once we've done our perineal punch, we're going to lift centrally on right above the pubis, and then halfway between the pubis and the umbilicus, give it a flick, that's all. If it feels like, or they've said, hey, I'm really uncomfortable here, then you can get in just above, kind of at that midpoint line between pubis and umbilicus. Just go laterally, come down, you'll fall down into just below the abdominal, rectus abdominis bulk, and then lift up and towards the midline. I will show you that. We might get a lady to volunteer their body to science in a moment and just show you what we do there. So, our corrections are mandible only, spread and release imbrication. Combination, spread mandible, release imbrication, spread maxilla, deal with any change in centering associated with that, because battle mode is not I'm standing neutral and I'm happy. Battle mode is different, and so your centering will change. There's a maxillary involvement. You're going to have some change in your centering systems. It needs to be reset. Once we do that, we need to reset your K27s, which relate to lymphatics, and also whether or not one side of the body is engaged more than the other in the battle mode. Okay? We're going to spread the maxilla again. Whenever we do that, there's going to be a parietal descent. Lift the parietals. We've got our contact for the parietals. My thumbs, the sagittal suture will bisect my thumbs. My hands will come over my fingers are on top of or scooping up the parietals as I breathe in and just put some pressure down, separating sagittal suture. Okay? And then once we've lifted the parietals, there'll be some sort of gallbladder reflex. Gallbladder reflexes are always involved in regeneration. Gallbladder's involved or gets involved in carbohydrate metabolism. Carbohydrate metabolism is a key function in regeneration. Hence that reflex shows up. Then we're going to put some tone back in the urogenital diaphragm, give it a bit of a lift on our ptosis, and then stimulate the diaphragm and the insertions into the pelvic girdle. That's it. Simple. So I just want to take one lady who wants to volunteer their body science. Thank you, Sandy. Because it's just slightly different. Okay? Could just turn around and make a face, everybody. Good. Let's see how, because we haven't seen Sandy since the last time she was here in Module 1, so we'll just have a look and see how perfect she is. Good. You changed your exercise regime?
No.
Haven't?
No.
Done more?
No.
Done less?
No.
Anything else you want to tell us about?
No.
That's good. Come and jump up. Relax in. So we're just going to scan, on your tummy is great, please. We're just going to scan over Sandy and move towards her. So we're going to check her centering systems. So interestingly, first thing we get with Sandy, as we release the heel tension, is she goes left short, she goes left long. So what are we thinking straight away? Yeah, pelvic, some low back, something, there's something here. Yeah, good, thank you. So hold this. She's strong on the left. She's weak on the right. Localised to C3. So we're going to go C3, right lateral. Give it a nudge. We've got C3, we're going to have a L3. We're going to lean on the spinous and the TP and separate them. And she's really tight here. Now, sometimes just doing this, you'll get a significant release. Okay? You'll get a significant articular release just by leaning on it. We're going to go on S2. She needs a good nudge there. Release the piriformis, lymphatic, vascular, lift it. I'm just going to scan over her lymphatics. She shows on the right, relax that one. So I'm going to do them all. Then we're going to go both hands on your buttock there, good. Just check that she's okay, eyes open. She's not okay that way. So we're going to go little breath. I had 2. So if you've got 2 here, we're going to assume we've got 2 here. So I'm just going to do them all. Little breath, huff and a puff. Pushing down towards the nose, rotating the ischial tuberosity medially and superior. Huff and a puff. Good. You sweet tooth? Had a cold? Yeah. Okay, so she's another one for tomorrow. Very good. Okay, let's have a look. It's all good. Have a lie on your back. So I'm just scanning over what we could do. Just checking a basic gait, scanning it. We check her patterns. You can see she's turning into gait, you know, bit of gait there. Left hip shows, right is good. So we're going to push this one up. We can go 2-hand therapy localisation for the iliofemoral ligament, iliotibial band. We're going to rotate that back into the socket. Okay, good. And we're going to check the universal cranial fault, tritonal left and right. So she shows a bit up top here, lifting the chin up. I'm doing the correction externally. I could go down the hard palate that way and do it internally. Lymphatics show up a lot. So we're going to give them a rub. And then eyes open. And eyes open it is. So we're going to go a little breath. So lifting up the wings of the bird, rotating the ASIS laterally and inferior. Yep. Good. Okay, buzzed over that. Check it. Not bad. Both hands on the back of the head. Just check her visual centres are in. She said you got to be joking. So we're going to plug it in. Once again, there's lots of reasons why we may centre in a certain way. Who had a 100% stress-free week this week? Absolutely nothing went pear-shaped. It was nirvana. Okay, so you're all going to have a gait problem to some degree. Most likely it'll return to some degree somewhere. Good. So Sandy's a bit resilient there, so you know it's a bit sort of resistant to change. So we're going to go eyes to your right, okay, and eyes to your left, same thing. So we've got front to back and back to front. I'm going to clear those, clear those, clear those, clear those. Good, well done. Go eyes to your right and eyes to your left. Now, one of the things that's happening for Sandy straight away is as we unlock this gait pattern, because we had a kind of little bit of a short leg and went long, so we said it's a low back problem. But look at this. Okay? So we lift up that innominate. So we know there's probably a category 2 here somewhere. So we'll get to that, lifting your head up. Try hold up. Not bad. She's strong from last time. That's really good. So just lift, just hold your head back or just check it. Hold down, push against my hand. Good, relax. Good, relax, relax. Now come up, now hold up. Good, she doesn't like to lose either. So Eyes open, little breath. Just check those things because you never know. Close your eyes. You want to make sure that most of the key things are done because otherwise you're creating work for yourself. And eyes open. There's plenty of work to do without creating more work to do. And eyes open. Good, look to your right, left, up and down. Look to your right, left, up and down. Good, look to your right, left, up and down. Look to your right, left, down. Good, look to your right, left, down. Little breath. Close your eyes. Mouth open, look to your right. Left up, down. Close your eyes, right. Left up, down. Good. And lifting your head up. And try hold it. So not strong, so we'll go a little breath. Good, little breath. Good, little breath. Our head's disappearing down this table. Hold it with a little breath. Just have a feel of their heads. Get used to having a feel of how that head's moving. Because it gives you a little window into what the head's been through, no matter what they tell you. Just what it's actually done. Little breath. You know, it's just like an athletic body. You know, you can kind of, it looks different. Well, a head that's been through a lot has a different, you know, tone to it. And we're just getting all those extended cranial injuries. So we just did sutures and then stimulate the centering systems. Lift your head up and try hold strong. We're going to pass here. There's more to do. Both hands on the jaw. And she shows up. Not really, so we'll go eyes open. And it shows up that way. Good, so we're going to just check. We're going to go cross to K27, eyes open. It's a bit there. She's not bad at all. There it is. So let's just have a little go at things. Unlock the mandible, mouth open. Now this is different. This is different. Okay. Now watch my hand. Now if I'm vibrating it, but if I don't vibrate it, there's no movement. So this dental arch is way more locked. The horseshoe is a mobile, bendable bone. And the more tension, the more stress, more challenge, the more you'll lock that bone. G'day, little breath. Now I'm putting some vibration in now, which is something I encourage you to do. There's a heap of bad jokes, I'm going to leave that. Because it'll help to get some movement in that bone. It's just another afferent, a different sensory pathway, obviously. But now I'm getting movement in that mandible. Whereas before, there was no movement whatsoever. Good. Unlock the imbrication. Could do it, you know, this way. You know, or use an activator, whatever you want to do, mouth open. Now, interestingly, you'll notice my hand here has got motion. It's actually moving. So there's less tension up in the maxilla, and her testing said that. It was really obvious down below, but when we challenged the maxilla to see if that was involved, not so much involvement. Mouth open, so we've done centering, reset the communication systems right to left with the switches, and then we've come up parietal to Murphy's point, and she's pretty, you know, for a young person, this is pretty hot on Murphy's point. Is that tender? Yeah. Yeah, so pretty tender. Give it a bit of a pump. Good, bend the knees up at 45. Good. Now, try and squeeze your knees to get hard as you can. Try and squeeze them, get hard as you can. Squash my hand, hard as you can. Nothing. Squeeze them, get hard as you can. Cool. So she's an unstable system with a stable exterior. You can tell anybody you like about that. Because, look at this, squeeze hard as you can. Push. Now if you get that, we're going to involve the reactive muscle chain. Squeeze out, squeeze out. Yeah. Now you can see that, that's much better. Push out. No problem. Now push in. Squeeze. Now we're getting some activity. Squeeze, squeeze, squeeze. Keep going. Squash my hand. Hard as you can. Push, push, Push. Now push out. Don't overload them. They can't do it, they can't do it. Let's go again. Squish, hard as you can. Okay, have a rest, have a rest. Good. Now push in hard as you can. Now we're getting somewhere. Keep going, keep going, keep, good. So, her legs are in about the right position. I can't miss. I'm going to get my contact here. I'm just going to give you a pelvic floor a little nudge. Take a breath and out. Good, take a breath and out. Take a breath and out. Now, if I was looking for ptosis, which I don't expect to find with her, I would come off the rectus abdominis down into that little furrow there and just therapy localise, and in fact we do see that she's down on the right a little bit. So I'm going to lift up and push up towards the midline. Take a breath and out. Good. Okay, and that's clear. And then we're going to go and stimulate the diaphragm. So we're going to push the fibres up underneath the rib cage, push the fibres down into the pelvic girdle, and then we should be okay. Both hands on the jaw. Strong. Thank you. Very good.
Thank you.
Thank you. So really good window there, because we could see, like the findings up here weren't so obvious, but the mandible finding was really obvious. And then when we got down to test the tone in the urogenital diaphragm, really weak. That doesn't mean to say she's got symptoms at the moment, but if you leave it like that for long enough, well, everything, you know, it's going to drop down. And we did find that her abdominal viscera was starting to move down into that right lower quadrant. So we did a central general flip, and then we flipped up from the right lower quadrant towards the umbilicus to lift it up and restore tone. Okay, we can have a play shop. So we're going to have a play shop. So just in groups of 3, grab a table and we will have a go at that bit. So was she weak on both sides?
No, she was weak on the right. Now it's gone to the left.
Okay, so when you get one like that,
Yeah.
if you get one like that, then what you want to do is just check yourself again. Rub the visual centres, check the strengths, and then identify, did she have an occiput? Because what the normal pattern would be is if you had a lefty, it'd swing to the right. But if you've got a righty, it's unusual to swing back to the left.
It started on the right.
Cool. So you got that? But what I do is just, you know, if you're getting funky findings, and if you've got it on the right and it clears, then unless there's a really good reason to keep looking, I would leave it rather than, because what will happen is if you go left, then it'll swing back to the right
Swing
again.
back to the right again, yeah.
You're going round and round circles. Left, right, left, right. Welcome everybody. Okay, so we've completed the first half of your defence unlock of moving your system from sympathetic dominance to a resting state. We had a whole heap of questions in that chewing cycle we just had then about, you know, where does it all fit in? Why are we getting, you know, centering reflexes showing up when we've got extended universal jaw? Just consider that what we're doing is restoring you from an adapted state to a neutral state. And that when we have centering systems show up, they relate to us kind of moving into this defensive or fight-flight mode. And we're in defensive flight-fight mode, or when you've had a cranial injury complex or, you know, velocity trauma or something like that, everything happens instantaneously. And what we were doing, which was what Adam so eloquently put, is we are sequentially going back through all the components and identifying, is this back to neutral yet? So what we're doing is we are compartmentalising a series of different corrections. But of course, all of those things, all those events are happening in an instant. We're just going back afterwards going, well, if we put all that back together, will we need to do this? Okay, we've done that, will we need to do this? So we're getting you back to neutral and restoring normal sequencing processes. If we go back to our three-brain model, we're allowing you to activate cortically and getting you out of being locked in one survival mode. So think about that as you go through, because then you won't get disappointed if, like, you know, you've done all these, you know, you did basic 8 and cranial injury, and then the person goes, well, no change yet, doc. Well, okay, well, there's more to go. We haven't cleared all those other things yet. We may not have cleared the adapted state in relation to the trauma that induced it. Is that kind of making sense? So think about everything that comes up in this corrective process as a smart adaptive state your body enacted to deal with the, you know, stressful input that was coming in. Because we'll take that conversation forward tomorrow into limbic in our relating systems, and this is where I think the neuroscience is catching up with what we've been doing in practice for, you know, sort of a century. Great. So it's a little hard to see all that, but this is a flow chart just showing you what we're doing. So we're going to test, we get a week this, we do a mandible section. We want to see if there's an extended component. We test the, thank you, we test the maxilla, it should say. Where is it? Down here? Okay. And then we go through this process of resetting the maxilla, and then our centering systems, which are not on that one, and so on.
Excuse me, Simon?
Yeah.
Do we spread the mandible and the maxilla both at the first molar, or is one of them?
Always at the first molar.
Okay, so the mandible.
It's always one correction. It's always in the same direction. It's always at the same anatomical site. So that's a rule of thumb to keep there. Thank you. That it's always at the level of first molar, and the maxilla and mandible spreads are just lateral. You can induce vibration if it appears that part of the dental arch is extremely contracted. Very good. We did our pelvic floor section. We had some interesting things come up in pelvic floor, and it wasn't related to the perineal punch. We definitely found that sometime when we did the CV3, or we basically flipped the abdomen to restore normal tonus, that we had some ptosis, and we had quite a lot of people where the abdominal contents had shifted often to the right. Okay, you know, if we're moving into right gait, then things may move there. So it's a common scenario. It's often hooked up with all sorts of trouble, including infertility, and lots of abdo sort of pain, dysmenorrhea and this and that. So don't get caught up in the other thing is in providing a solution based on a recipe. What I'd hope you get from this weekend in conjunction with your Module 1 work is that you start getting a wider vision of where you're going. We stopped there in our previous section and we went back to basic 8 and cranial injury because I wanted you to make sure that those systems had been reset to neutral or close to neutral before we went on to try and unlock the jaw. Because if we go, oh, look, John's got bedwetting, okay, I'm going to do basic 8 and universal jaw, well, that's only part of a whole reactive muscle chain that we know is there if there's a cranial injury pattern. If there's no CIC, that's fine, but if the cranial injury pattern's there and you try and get a result with layering in the next section on universal jaw, you might be disappointed. Similarly, if there's a raving category 2 or there's pelvic instability, then once again you may be disappointed. So it's really important that you've actually got a bigger vision of where I'm going with this. That I'm pulling them out of adaptive state to neutral. And there may be a variety of things to check in the systems to make sure that they are actually in neutral. If you've got holes in a bucket and you only plug some of them, the bucket's still leaking. The problem may return. Particularly, you know, when we're moving, we're focusing on health promotion rather than symptoms. You know, very often people come in because they've got symptoms, right? They're less commonly come in because I just want to check up, doc, and I know that when you adjust me and reset all my systems that I'll be healthier and I regenerate far better than I used to. I mean, wouldn't that be nice? Well, that's the consciousness I'd hope that you start sharing with your client base, because that's what's going on. When you look after them, they regenerate better, and that's the whole process. Is you're an impermanence. You're regenerating anyway. You can either get behind or get in front. What do you want to do? What sort of body do you want next year? It's all about allowing for us to return to a neutral state, or be in a neutral state as it may be most of the time or more of the time, so that you are actually moving towards regeneration and out of defence. Any questions on universal jaw? There's a section in your manual on hiatus hernia. Okay, and in your notes, it's got a section there that says tuck the diaphragm fibres back under the rib and into the pelvic girdle, which should really have appeared as part of your universal jaw complex. We have taught you to do that way anyway. The hiatal hernia technique is the next step that you would use to move the stomach, or the top of the stomach, the cardiac end of the stomach, inferiorly caudad. You can see there's a process there, and we might just go through that with one person just to kind of complete that section. So you can use universal jaw for lots of different instabilities, lots of different adaptive states, lots of different symptom profiles. So really anything that's unstable in your abdominal area, or that's affecting your respiratory zone in terms of the visceral function, we can use, we can interface the universal jaw in there, but once again, make sure the other adaptive states are cleared first. You're looking worried? That's good. Because you come in late, you have to get you to volunteer your body to science, the concentration phase. Cool. Okay, are we okay with that? Very good. So we might, maybe Lana, because maybe if you come up, would you be so kind, please? Now I'm terrible with names, so if you haven't got a name badge on, thank you. I will probably, not get your name right, I'm sorry. So it's good, at least today, to help me by wearing a badge. Come and have a lie on your tummy. I'll just check, just to make sure our pattern, then we'll just do a hiatal hernia thing. And also I want to check someone who's had an atlas adjustment in the, we're going to use you, perfect, in the last 24 hours. So we're going to just check that our category 1 situation is stable, that we don't have any obvious stuff going on. We just see a little category 1 with her little breath. C3, L3, S2, piriformis, clear it. Good. And we'll just check your lymphatics. She's okay there. Have a lie on your back. So if we could just go to the hiatus hernia section on that. Have we got a slide on that? Both hands on the jaw. So we're going to assume her universal jaw was cleared really well. Close your eyes. Okay, so we're going to go back and reset that once more with eyes closed, and then we're going to just challenge this cardiac area of at the top of the stomach, and we're going to make sure that it's an extended. Close your eyes. One. There's a little bit there, but it's not bad. We'll go mouth open. Little breath. Good. And open there. Her maxilla is the tight bit. So she's going to have more in the extended universal jaw. Good, a little breath. Someone asked me, why is it that we've got K27 showing up in this part of the protocol? Well, we've just done our centering systems, and the K27s, the switches, are there to reset left and right body communication. So when you're, being chased by the saber-toothed tiger, you will adapt in a certain way involuntarily to deal with that. That's what we're doing. We're just taking you out of that pattern. Now, she's got a fair bit of stuff going on with the gallbladder here. That's a bit uncomfortable, right? Yeah. Bend the knees up. Now, she just had it done eyes open, so go eyes open, squeeze your knees. Strong as an ox. Close your eyes. Not there. Okay, squeeze hard as you can. Squeeze, squeeze, squeeze. She's not turning on, push out. Squeeze in, squeeze, 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 turning on now. Squeeze, squeeze, squeeze. If they're not turning on in, it'll go back in the reactive muscle chain. Squeeze out. Push in. Good. Little breath. Good little breath. CB3 flip, little breath. Cough. Good. Push the diaphragm back up and into the pelvic girdle. Check and see if there's any ptosis. There's a little bit on the right. Lift up, push towards the diaphragm, cough, give it a flip. Cool. Now, with a hiatus hernia technique, we're just going to gently push up underneath the diaphragm, right under the xiphoid, push cephalad. Now, pick you because I wanted to pick on you, but we can see straight away, I don't have to do anything, just straight away we've got something going on. Now, she may not have a hiatus hernia, but there's some sort of, superior movement here, which we want to knock out. So we're going to go a little breath. And I'm just a little pressure downwards. And cough. Good, give it a flick. Push the fibres up again. Make sure when you're pushing up that you've got the rib cage, you're pushing down, the hands going underneath. Good, 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 good. Okay. Okay, and we'll push up again. Not bad. So you got some allergy things or something like that? Yep. So we're going to get to that tomorrow. Very good. Okay, cool. Thank you very much. So that's all it is. So basically we're going to challenge cephalad, we're going to challenge superiorly under the xiphoid to see if there's anything going on. If there is, get some pressure on it, pull downwards in relation to whatever tension you've got. So sometimes it's minimal, sometimes you need a little more pressure. Cough. Remember your diaphragmatic function and stability relies heavily on your category 2 stability as well. So when we're thinking about diaphragms, think about category 2 and universal jaw as key drivers. Not the only thing, but they're key drivers. Great. Lana, let's just check you. Just jump up. I just wanted to have a line tummy. Yep. And good. So, cool. So let's just check Lana and just see what shows up. So she shows short, stays short, Atlas, right? Okay. Come and have a stand. Good eye. Now, have you got a name badge? Yeah, can I have your name badge? So we're going to, this is our business card. So why don't we go mouth open? I'm going to bite on that and just cheer around, walk around, swallow. That's it. Cool. You can get this on YouTube tomorrow. Now come and have a lie in your tummy. Okay? Nothing. Okay, so what do we do?
Straight to jaw.
Other than get it a bite on a name badge. So we disengaged the craniomandibular stomatognaathic system. We unlocked it temporarily by getting her to bite down on something that separated the condyles and getting her to swallow and just to kind of temporarily take the system out of whatever it was doing. And I wanted to show you what happened to her atlas subluxation, because I know that she's getting checked somewhat regularly, and it's highly likely that the jaw is part of the reason that we're resetting back into whatever adaptive mode that we're getting stuck in. I mean, who has patients, clients, practice members that come back with the same stuff? Part of the caper is that they're getting stuck in the same adaptive state. Thank you very much. So we'll get to that later. Very handy card, that one.
Thank you.
Awesome. Cool. So that's universal jaw. I just wanted to show you that sometimes, you're working away and you're just trying to get that upper cervical complex stable. Well, maybe you've already done the right thing. But as we mentioned, the next part of the adaptive chain wasn't sorted out. And then there's another part and so on. Cool. Next bit is defensive jaw. So we talked about earlier on, we got a head nearby. We've got one of those. We said earlier on that we were going to unlock, the horseshoe and unlock the osseous or the cranial system and unlock the defensive jaw, the universal jaw fault. which is what we've just done. So we've basically unlocked that mechanism. What we haven't done on purpose yet, we've influenced, but we haven't done on purpose, is what my good old and our great colleague Dr. Goodhart told me in Sydney in 2000 when I asked him, well, we've just been through 10 days or a week of AK straight with the Dirty Dozen. I said, well, tell us, George, what do you reckon is the number one thing we need to do? That's what he told me. He said, clear the juror, everything else is frosting on the cake. Quote, unquote. It's on audio somewhere in the AK annals. Next step, we said, well, if we've got this lock on the outside, then we've also got a lock on the inside. And the lock on the inside is the action of your muscles of mastication, or particularly masseter and temporalis. Remember, our temporalis is going to protect that weak spot, that thin bone, the saucer, the temporal bone. It's going to, the action of that muscle, the increase in tone will lock that bone. Masseter and temporalis and are reactive to the opposite lateral pterygoid. And that side is reactive to that side. And the action of the pterygoid pulls the wings of the bird, the sphenoid, down. And at the other end, labeta ani, pubococcygeus, pull on the coccyx. That's what gives us a top and bottom lock in our dural system. That's why when we injure our coccyx, for example, it's sometimes a really destabilising influence. And some providers will, number one thing they'll look at with people with serious brain injury profiles or aberrant motor activity profiles like epilepsy is go straight to the coccyx. Because the system is disturbed once the coccyx is disturbed. So our next step, we've unlocked the vault on the outside, is to unlock the vault on the inside. Remember, when the cranial, spinal dura enact, there are no stretch fibres in the long axis. It's stronger than tensile steel, and it forms a connective tissue barrier for the brain and spinal cord to be protected within the cranial vault and the spinal column. So our next job is to unlock that pattern, is to release that lock on the cranial and spinal dura, and then to make sure that if there's any relationship with the bridge to our fascial system, particularly to our cervical fascial system, that's released as well. Okay, so this is a key concept, and you can just nod your head like, yeah, we've heard enough. That we've got a bony lock on the outside, and then we've got this soft tissue lock on the inside, enacted at the cranial end and at the caudate end simultaneously. Outcome is the body gears for battle, locks for battle. And there'll be changes all the way through your spinal and cranial system. There'll be significant changes in the tone of the cervical fascia and the fascia generally. So we'll see people move differently once this is unlocked. So their range of movement, their passive range of movement will change significantly in some situations once this is unlocked. Sometimes you get 10 degrees, but sometimes it's 15 or 20 degrees or more. Very good. We know our muscles, masseter and temporalis, and the opposite lateral pterygoid. Very good. This picture is just really to show you what's going on when the coccyx end and the cranial end are put into tension or activated. The fascial defence system is the external body bag that you live in, that gives you form. So we need to release here, and we need to release here, and then we need to make sure that the bridge through to the cervical fascia and then the body fascia is unlocked. That's it. That's how simple it is. We've done an external lock, we've got an internal lock to undo, and all we have to do is unlock masseter and temporalis and opposite lateral pterygoid, and then unlock the spinal dura, and then we need to make sure that the fascial system is released. Now the relief in this is that there's a spinal component. Yes, we've got one today. And that is that we're going to unlock the cervical fascia and the C-spine through a stair-step process. So they're kind of there are a few components, but really just three components, which is unlock the skull, unlock the dural system, and then unlock the fascial system. How are we going?
Good, but you need to go straight into
Okay. So what we're going to do is get a victim. Sandy, if you would. Is that okay?
Yeah.
If I call you up and you don't want to be in, just let me know.
I'll let you
You okay?
Yeah.
Okay, good. So just go nose down. We'll just check that she's clear. Good. Now, what Sandy keeps showing up with this is this left kind of category 2 thing, so we'll get to that soon enough. So a little bit of category 1, a little breath. We'll just reinforce things. Good. So you had an old back problem? Something going on here. Have a lie on your back. And we'll go both hands on the jaw. We're okay there. And then we're going to, the next step is to just have the right hand on the jaw. So right hand on right jaw is our biomarker, is our input for defensive jaw. Okay? Relax your legs. And we'll just check her leg stretch. So she's sort of almost 90. And yeah, she's almost on the ballet team. So it shows up that there's some sort of defensive pattern. And so what we're going to do is to try and turn that off, turn off the engagement of the protective system, the lock within at the top. So we're going to spindle off, we're going to turn down the activity of masseter and temporalis, and then we're going to go mouth open and just give the lateral pterygoid a little nudge. Then we're going to go the other side, masseter and temporalis and opposite lateral pterygoid, and then do a mirror image. So one side has to work with the other. You can't have a lock on one side, so to speak. You can't lock the bag on the inside from one side. It's got to be one side to the other and back the other. And then we're going to go head to the right. And then we're going to go head to the left. Yeah, come around and stand up if you need to have a look. We'll get others up shortly. And then that's good. Now, the other thing we might want to check is there some distortion pattern that the body's locked in? So what I could do is just have a look and see if I get her into a twist, does it show there's any response? And there is a bit. So I'm going to put her into a twist. Actually, we'll go this way. Good. So we just said, I'm going to unlock the bag within neutral. Then I'm going to get you to rotate to right and rotate to left. And then I'm going to put your body or your dural system into torque, which is what we've started to do with our category 1. So we're going to go here, masseter and temporalis and opposite lateral pterygoid. Then just do the mirror image, turn the head to left, legs to the right. Okay, and here, and here, and here. Now, the next step, we said, was to make sure we release the dura and the cranial dura, the spinal dura and cranial dura together. So we're going to get on the tailbone and we're going to either get them to hold the greater wings of the sphenoid. Remember we said that's being tensioned at the top, little breath. We're going to go the other way, little breath. We'll come back to your notes in a minute. I'm speeding your notes up. Then we're going to go back to the centre, little breath. Little breath, three or four breaths on each one. You want to be on the tip of the coccyx. You're not forcing it, you're pumping it. Little breath. This sort of pumping. Little breath. Some of them are tighter than others. Just work with the pressure that's there, but it's not lots of pressure. Head left, head left, head left. Good, little breath. Good. Back to neutral. So we've unlocked the system. We've released the system top and bottom. And now we're going to go up to the bridge between the meninges, the dura, and the fascia in the upper cervical complex. Give it a rub. Remove basically on your dural insertions. Occiput C2. Just give it a shake. That's that. That's all we need to do there. And then what we want to do to release the C-spine and cervical fascia is just go through the 4.5 steps from C7 to or T1, C7, 6, 5, etc. up to the occiput and unlock the C-spine. Because if we take the C-spine up at the moment, you'll notice it's moving as a unit. And what we want to see is it unfolds through those steps. Not happening. So what we're going to do is just engage C7, T1 and then get her to lift the chin up and down. And as she lifts the chin up, I'm going to just gently resist her. Now I'm not going to use lots of pressure on my hands. I'm just going to get into position, and once again I'm going to lean in. You can have a like a more standard vault hold. I prefer to just to get under it, and it's not as hard. Nod the chin up, and as they come up and down, go down and breathe in as you come up. And I'm just going to just gently, Kurt, welcome, have a seat. We're just going to gently walk up through the 4.5 steps. More or less. Cool. But just conceptualise those junctions. Nod the chin up. Get them to huff and a puff. Inspiration, expiration will get things moving. It'll speed up the correction. You'll notice as we're getting towards her upper cervical complex, on the right side, quite difficult. Left side, nodding. Good. Relax, relax, let it go, let it go. Now sometimes it's a bit uncomfortable, mostly for the doctor, but sometimes, it's uncomfortable for them too. Nod the chin up. Good. Turn your head the right side and left side. And we're just going to stretch out that cervical fascia and then turn the head into rotation. Just push around and then push around. And then we'll just give it a little rub along the insertion of the fascia, through the bulk, all the way up to the bridge. Rub between the spinuses. This is where you'll feel that there's any residual subluxation. You don't have to go very far. Once you rub between those, the interspinous spaces, you'll feel if there's still something that needs to be adjusted. And there sometimes is, sometimes there's a 5 and a 6 and a 7 and you just don't know what's in there. Cool. Relax. Thank you. And then relax your legs, let it go, let it go. Now she's come out a bit. It's not huge, but, she is, getting towards 90. More so on this side, we can see this side comes out. So we check the other side. Then I'd be suspicious that there's some hip involvement. Relax it. And I'm just going to have a little look around on this hip here. Now this may be to do with this posterior nominate caper we haven't dealt with yet as well. Relax it. But straight away, much better. Thank you very much. Good-o. So, 3 things there, just to simplify what's in your notes. We had a lock at the cranial system, masseter and temporalis and opposite lateral pterygoid, pulling on the greater wings. The other end's pulling up, the dural system locks, pulls the brain away from the side of the skull, provides a central connective tissue cylinder for the spinal cord to have extra protection. We need to unlock it at that end. Then once we've done that, then we're going to unlock the dural tension by contacting the sphenoid and coccyx and releasing it in whatever plane we found it. The planes we checked it in were neutral, head right, head left, head right, body left, head left, body right. And then we released the fascial system, focusing on the cervical spine and connective tissue bridge, To augment that, we released the C-spine through a stepping process. It's just, you know, for those who've been in SOT will understand stair step, but essentially we're just releasing the cervical spine in a sequential way. What you'll find is you'll tap into areas where perhaps the existing or initial care wasn't as you know, didn't clear all of the components. Whereas when you do a defensive jaw, clear the C-spine, a lot of residual, you know, connective tissue, spinal, and other joint dysfunction is released. So it's a kind of a nice way just to clear out all the mess that was there, and there may still be things that are left. There might be a, you know, like a specific listing subluxation to clear out. Okay. Very good. So what we'll do, Kurt over here, thanks Kurt, hi Kurt. Kurt's a very resilient human who's a student with us in Australia, originally from Estonia. And so Kurt's had some trouble with sinuses. He's had a sinus clearance procedure and he's getting soft palate spasm afterwards. Is that right? Yeah. And so there's a whole story here, but I thought I mentioned it to him and he generously said that he would volunteer his body to science. Thank you. I can't guarantee when you'll get it back.
We're going to workshopping now.
Yeah, cool. Got that. So after workshopping, we're going to hang out with Kurt and go through his process in more detail. So I want you to go and play with those 3 components of defensive jaw. And because we've done everything up until this stage, we can do it all together. So get someone on the table, we'll get started and open the circuit with a right jaw TL, and then we'll go through those 3 pieces. So basically we do right jaw. Yep, and then we're going to go, what we could test for, usually there'll be a rotational thing, but usually it's just there anyway, she shows up, and then we could go this way. Okay, so I could just contact the G medius on that side and test them. So I wouldn't reach through anybody's legs as a rule of thumb. Great, so have low tummy. So what we'll do is I've seen Kurt twice. We're just going to screen him for where we got up to. So we're just going to go whip over basic gait cranial injury, and then we'll go universal jaw and defensive jaw because I haven't done any of that stuff on him yet. And then he's volunteered to come back tomorrow, very good of him. And we're going to go over digestive jaw as well because all of those things will influence this palate tone. So we're going to just check out his basics and just make sure that he's okay. So he comes up a bit short. And so we're going to give this a little wiggle. Now, if you've got someone like this, you know, and the thing is the palatal myoclonus, it's questionable whether it actually came up after the surgery or was there before.
It started a little bit before surgery.
Okay, there you go. So there's something, you know, something's happened to his head and jaw. He doesn't have a history of trauma that we're aware of. Good, don't turn your head there. But he does have a history of eating sweet things enough when he was younger that most of his teeth have been replaced. Is it okay if I tell everybody secrets? So, you know, there's been dental stuff going on. Stuff's been done. Good, we just check that. So we just did category 1. I'll just check him on switches. He's not too bad there. Wasn't too good the other day. I want to make sure that centering systems are good. Eyes open. Little breath. Good. 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 Close your eyes. Little breath. Good. Have a lie on your back. Good eye. See if you can lift your head up and check in the clear. And what did we forget to do? Universal cranial fault. Try turn left. All right. Doesn't seem to be anything there. We'll just make sure that this is okay. Try tongue left and tongue right. So I want you to poke your tongue out to this side. Good. Poke your tongue out to this side. So you've got an occiput something. So we're going to go around, let your head relax. Good. Good, and give it a nudge. And we're going to go in here. I'll just check the hips. Hips are a bit here. Good. Good. Bend this one up and give it a wiggle. I'm just scanning over those things. Good, eyes open. Close your eyes. Good. A little breath. So what we're trying to do is to get ourselves in a position where we've got lots of variables that could influence cranial function and soft palate function out of the way. Lifting your head up and try hold your head there. Good. And just go relax there. Just hold your head back. Good. Just hold back. Hold. Just push down. Good. Relax. Now come up. Hold it up. So one of the things we find with him is this, cranial injury pattern. Eyes open. Close your eyes. Can anybody think of anything else where soft palate tone or congestion becomes a problem? Sorry? Autism. Okay, yeah. Something common that lots of people have that bothers them at night. Yeah, snorers. So that's a soft palate tone or congestion issue. So, and little breath. And what we know is that if your cranial system is working well, that you're less likely to have aberrant tone or congestion in your soft palate. So lots of snorers get better when you do basic 8 on them. Good. And we go mouth open. Look to your right. Left up and down. And close your eyes right. So we're just getting those scenarios out of his picture. Just lift your head up and try hold it. Now what I'm going to do there is just make sure we just get on these pterygoids and the tonic neck reflex so we can open up the airway. Matt Hamilton said earlier, he was talking about, look to your right, lift up and down, close your eyes right, lift up and down. Good. Maxilla, imbrication and retrusion of the jaw and keeping the airway open in mouth breathers and kids with issues. And little breath. And in a way, something's happened to his system where he's probably trying to keep his airway open, not voluntarily, involuntarily. And there's something in the way of him maintaining tone in the soft palate. Good. I suspect the sinus infections aren't just related to mechanical pressure, by the way. Try hold it up. Good. Cool. So we're going to check our universal jaw, both hands on the jaw. Just both hands like that, Kurt. Well done. Good. And we're going to go drop your left hand down. Good. And relax. So just let your arm come down. And we'll just check his fascial tone. Before we unlock all of this, let's just see what it looks like. So he's not going to get on my ballet team yet. So what we're going to do is we're going to just open this up here and open this up here. It won't hurt you, but there'll be a little bit of pressure on the jaw and on the hard palate. Is that okay? Go mouth open, doing a great job. Little breath. Now, there's movement in the mandible. Good. And open there. Little breath. Little breath. Good. Okay, so we've gone through both sides. Now what shows up with him is a heap of pressure at Murphy's point. Heaps of pressure. Bend the knees up. And good, squeeze the knees as hard as you can. Squeeze, squeeze, squeeze. Squeeze, squeeze, squeeze. Squeeze, squeeze, squeeze. Pretty good there though. Yeah. Neurogeneral diaphragm's not bad. Little breath. Little breath. Cough, cough. Good. Just make sure his diaphragm's clear. And then we're going to go to defensive jaw. So we're going masseter and temporalis, so we're spindling off and opposite lateral pterygoid. Masseter and temporalis and opposite lateral pterygoid. Good. Good. Good eye. Turning your head there. Good, leg to the left side. And we're going to just put him into a twist and just kind of speed this up for your benefit and unlock it. Good, turn your head left side. Legs to the right. Good. Now we can see also as he goes around into body talk that he's got limited movement in his lumbosacral junction. Little breath. Could be independent. Good. Let's go the other way. Little breath. Back to centre. And little breath. Good. Okay, so we just going into the fascial system. So we did the cephalad unlock, then we released the dura at the coccygeal end. Then we're doing a cervical fascia or fascial system release, nod the chin up. Now, there were some people where you were doing this standing up and whatever. I suggest you're seated or at the level where you can put some pressure on. Your pressure wants to be equal and opposite what they're pushing back towards you. Otherwise, you're working. You're actually physically got this 10 kilogram object. It's like going to the gym and having it out there and pushing it around. You want to be in on it, nod the chin up and down, and let them do the work. You're just leaning on them. They're a PLP for you. You know what they are, don't you? A PLP? Public leaning post. Good, I nod the chin. Got a few smiles. The room's hotting up. Good. And okay, I want you to just to breathe as you nod up. So breathe in. You know, if it's not moving, getting breathing. You know, it's the easiest, simplest thing to do that doesn't take any work for you. Nod the chin up. But what we can see with Kurt is how limited the motion is here. It's really limited. Good. And nodding. So is palate tone voluntary or involuntary? It's not a, sorry? Yeah, it's involuntary because it's a breathing function. So we don't have to think about it, it's just going to, you know, get in and out of the way. So when we're getting trouble there, turn your head the right, something's happened to that survival system or that set of cranial nerves that are stopping that area functioning properly. Good, relax your legs. And we just see what happens now. Let your leg come out. Okay? Straight away. So what you can say about, you've been a dancer at some time, Kurt? You haven't been in my dance class? No? Hips are still unstable. He's kind of got that super elastic sort of body. And it should, you know, be pretty flexy, but it hasn't been. Just mouth open there. Good. 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 Bite. Cool. So the other thing we could do with Kurt at the end of cranial injury to release the tension in his facial bones particularly would be, if we had someone with cranial injury and that had an impact, particularly a facial impact, what would we do as an extra to make sure that the facial bones started to work independently? Cookie jar. So we could do that one, mouth open, and just lift up the maxilla. And what happens when I lift his maxilla upwards? When I'm saying the cookie jar, we're talking about shearing the maxilla away from basically from the sphenoid. But when I lift his maxilla upwards, just relax, what we see is lots of no movement forward. And if we look at, just go look up. You okay there? You all right? Good. Good. Come here, look at this. So what we're going to see here is, you're a good candidate here. What we're going to see, don't worry, they're all nice people. They all care about you. Is that this system is not moving well. And one of the things that shows up is if you look at the canthus of the eye, the medial canthus of the eye, you'll see loss of motion. So if we look at one side, this side, there's lots, you can see my hand, it's just moving really nicely. And you look at this side and there's not much movement. See the difference? Okay, so in a situation like this, what we want to do is to release the facial bone. So we're going to go mouth open, relax there, little breath. So I'm just going to counter-rotate. I've got the greater wings of sphenoid and the frontal bone in my left hand, and I've got the maxilla in the other one, and I'm just gently counter-rotating. And then I'm going to lift the maxilla forward while I push the zygoma down. Doing a good job, hang in there. Lift the greater wings up while I lift the maxilla forward. Good job, you okay? Good man. So if we go back to it now and we look at the movement on this side, still down but starting to move. See this? There's starting to be action there, whereas it was all on the right canthus. There was movement there, and the left one there wasn't much movement at all. He's still stuck on that side though, so mouth open. So given that anatomically, as far as I'm aware, that the soft palate hangs off the hard palate, do you think that might be a factor in this? Little breath. I'm just getting some lifting here, which is much better. Little breath. Sometimes you've got to watch out for a gag on these. So this is an addition to cranial injury, basically. And just relax there. Doing a really good job. All these weird people are here to look after you. Rock on. We're done. Sorry?
Are you lifting superiorly or anteriorly?
So what you do is you shear the maxilla and the sphenoid and frontal bone away from each other. Yeah. Then you're lifting the maxilla up, and so sort of towards the ceiling and inferior like that, okay? And lift push the zygoma down as you do that, and then you lift the greater wings up as you lift the maxilla, towards the ceiling and inferior. So it's a separation. Thank you very much. You are free. Oh. So just please thank Kurt for coming in. Thank you. It was just a little window into an application. So we've had our cranial dural unlock. We did universal jaw and defensive jaw. Bony unlock, then our connective tissue, our dural system and fascial system unlock. Some components to that, there's some technique in there. There's some technique that involves doing less work. And I want you to be efficient when when you're doing particularly that stair step move. A lot of people will find that you're just not that strong. Thanks again, Kurt. It was really awesome. Thank you. That if you hold them out here and you're trying to do this, you're going to get really worn out. And I think all of us who've been in NOT practice for a long period of time, I had a bad reputation for going to sleep on people at rock and roll shows. The stand-up rock and roll concert, lots of noise, and I'd be nodding off on the person who's standing next to me, just leaning on them. So you can burn off a lot of energy that you don't need to. So technically you need to watch out for that. We're just going to, Matt Hamilton wanted us to check him out, which is good of him because he also had some really...
You wanted him to be checked.
Oh, is that what happened? Yeah. Okay. And then we're going to move on to pelvic injury, and we'll workshop that, which is kind of like the pelvic injury complex is really the caudate end of what we're doing with defensive jaw. Remember we had... No, I retract that unconditionally if I've offended you. No. Very good. Remember that we had masseter and temporalis and opposite lateral pterygoid initiating the sphenoid tilt, the tensioning in the sphenoid that got the dural lock going at this end. So if we look at our reactive muscle systems in our lumbopelvic area, we've got masseter and temporalis and opposite lateral pterygoid, we're going to have G medius, QL, and opposite adductor. So if the pelvic system's been injured, and we know that because we found 2 cloacals in the same eye option, okay, then we know as we get to defensive jaw, we're probably going to have to come back and reset the tone in the reactive muscle system in the pelvis. So we've got a reactive muscle system here, masseter and temporalis and opposite lateral pterygoid. It goes right to left and left to right, and we do the mirror image. If we've got a pelvic injury complex, then we're going to have right goes to left, so we're going to have G medius, QL, and opposite adductor. So we're going to start on the left. Okay? It's just the chordad representation of our defensive jaw lock at the top. So it's our reactive muscle system in action. Are we okay with that? It's one of the corrections you're going to do that doesn't, it's not like you do it and it's, wow, that was amazing, Doc. I just feel a lot better. But you'll find that people do hold their adjustments better, and it does complete the sequencing of returning that adaptive state to neutral, which is what we've been talking about right from the beginning with pattern recognition theory, is to restore the pattern to a neutral pattern from an engaged or facilitated unresolved adaptive state. Okay? So what we might do is use the whizzer. So like we said here, we've got this hypertonic TNJ, engages that cranial lock, causes reactive hypotonus. Reactive hypotonus. If we are hypertonic here, we must be hypotonic here. They're both weak. Hypertonic muscles are weak. They weaken on load though. Hypotonic muscles are weak in the clear. And that's the reactive muscle relationship. So you'll see it a bit with the persistent lumbosacral dysfunction. But what I kind of like to see is that you consider it outside of a recipe for my back pain people, and within this concept of restoring optimum neutral function. There's our relationships again. So what we're saying up here in the cranial lock, or the dural lock, is we've got masseter and temporalis and opposite lateral pterygoid. So we're going to have G medius and QL and opposite adductor, because the relationships are always contralateral. Are we okay? So just think top down, not bottom up. 15 years ago or more, maybe 20 years ago, I did a seminar with SOT instructor Jonathan Howard, and he introduced the concept of ascending and descending subluxation patterns. Okay? And so what they were talking about there was, well, most of the chiros who haven't been in SOT haven't had any cranial work done, so their patterns are all descending. And you know, if you haven't had any care at all, then maybe you've got ascending disafferentation or ascending noxious afferents from subluxation in the lumbopelvic area or in the feet or wherever it happens to be. So that's the key. Think about it top down. Most of the breakdowns you're going to see in practice will be the fact that these descending patterns haven't been cleared. So that these hypertonic kind of reactive defensive patterns haven't been unravelled. Okay? So that these active hypertonic reactive patterns have not been neutralised. That's the common cause of most of your breakdowns. Very good. So what we'll do is, as Matt mentioned, that we're going to have an interactive release on his TMJ, and then we'll check him for pelvic injury. And then we'll go and play shot the pelvic injury area, because it's very simple. You know, we've just got 3 muscles and we're going to reset the tone. So we're not going to spindle off because it's hypertonic. We're going to spindle them on. We're going to increase the tone in those muscle groups. So we're going to spindle on QL and G medius and the opposite adductor and vice versa. And then we're going to stimulate the lumbar riding reflexes in the lamina, particularly of L3 to L5. So the tests we went through today were 2 jaws, universal jaw. Right jaw, okay, was defensive jaw, okay, and then left hand to right jaw will be pelvic injury. Thank you. Universal jaw, defensive jaw, pelvic injury. In Module 1, we had left jaw for Category 2. And we put Module 1 together in that way because we wanted you to have a window into that structural system. But really, Module 1 and Module 2 go together as a complete unit. So you could start with Basic 8 and go Basic 8, cranial injury, universal jaw, defensive jaw, and then limbic system and digestive and valves and Category 2 and 3. So what we're doing today is looking at these protective patterns. So today is all about this defensive and protective system. And the pelvic injury complex is the completing element of what we've been discussing with your defence system. Okay, thank you, Julie. And thank you for bringing it. So what we're trying to do this time with the seminar process is to engage you in concepts as well as details. And Julie's just picking me up there. I'd left out some reinforcement in terms of details because it's not our PowerPoint. So what we'll do is we'll test Matt on universal jaw and defensive jaw, and then we'll check and see if there's a pelvic injury complex. We know it'll be there because when we started, they had 2 cloacals or 2 pelvic centering deficits in the same eye option. It says, look, this system's been damaged at some time. There's an injury. So when we get down the track, we know, well, we'll probably have a pelvic injury complex. Sometimes our systems reset themselves. That's what we trade on. We make an input, allow the body to go and organise it, and very often we get a great result. And what we're doing with this defence process is making sure that each of those pieces of that protective puzzle are resolved to neutral. Is that okay? Very good. So we just check Matt, and we just scan him on Basic 8. See what happens. He looks okay. Check the ones. So what we see with Matt straight away is a weakness on the left. So as a rule of thumb, if we see a weakness on the left, what's the first thing to check? Okay. So we're thinking, well, most common patterns, right, Category 1. So if we checked occiput, it might be that. So we're going to go up and test that straight away. Okay. It comes up straight away. So I'm not going to, I could go and test the other side. Weak, strong. But I know that, well, if that goes to that, if it was a Category 1, it'd be C3 on the left, wouldn't it? That would knock that finding out. So just in terms of having a little window into where he's going, good. We're going to just unlock those patterns. Good. And he's got a fair bit of posteriority in his sacrum here. You can look at, if you look at my hand go down, there's not much movement. And we're having to really push that. So we know that, that's a big pattern for him. We might come back to that another time in Module 3. Strong. If he's strong on this side and he goes weak again, what are we thinking? Might be Category 1. It's a little bit there, a little breath. It's just going to pump it. It's probably been dealt with today. Relax yourself. When was your back injury? Yeah, when did you have a back injury? Okay. Eyes open, close your eyes. Have you played footy? Yep. Little breath. Little breath. Good, eyes open. Close your eyes. So I played footy. And just recently I had a MRI and you can see that my pars fracture is nicely healed from when I was 13 and a half years old. but it's still there, really clear, really sclerotic zone there from footy. So the nature of contact sport is that everybody gets hurt. It's just how well you adapted to getting hurt. Have a lean back. Relax. And so that's not wrong. So I really like, people playing whatever they want to do within reason, unless you get knocked out 5 times in a row and you're going to kill yourself. I'd probably advise them, well, you maybe should think about doing something else. But I kind of look at our role is to keep people healthy within their sporting pursuits, which I think it's normal for them to be unhealthy at the moment. The whole concussion discussion that's got going internationally confirms a few things. But number one, that their brain health has been compromised because they're not getting the care and the neural activation that we can provide as a routine part of their participation in their chosen sport. What do you think about that? So it shows a bit on hip, good. And we'll try tongue left. Mike, he's okay there. We're going to check here. So what are we going to find? Probably 2. Hold this up and close your eyes. Yep. And then we'll check here. So we're going to just keep those going, a little breath. Turn them on, just doing them both together. Now you can rub them, but I want you to move them bones to start off with. It's much more powerful, and there's much more. Remember we started off with the slides at the beginning with our craniosacral rhythm and the cranial motion externally and what the brain was doing internally and the movement of the reciprocating membranes and the CSF flow from that. I think you're going to get a lot more motion of that in these new people when you do the manual corrections. And close your eyes. Good. And little breath. What position did you play?
Rover.
He's a rover.
Oh, I got hurt.
Yeah, I was a ruckman. So my job was to hurt everybody, including all the smaller people. Yesterday morning I was adjusting a really lovely family, and the father is an all-Australian player, and he's 40-something, still playing. Really nice guy, really gentle, nice man. And they lived part in Sunshine Coast, part here. And he said to me, look, I saw this guy before the game having a bit of a joke, and this guy's from Victoria, and he said to me, it's a bit soft up here. No one plays rough. It's all a bit soft. So as it turned out, they were supposed to be playing on the same team, but the other team was short. So this guy, the All-Australian guy, we'll call him Paul, played the other team anyway. So he tackled this guy. The guy was whinging about it not being rough enough. And as they were, he tackled him to the ground. And as they were coming out of the ground, he just turned around and just pushed his face in the dirt a bit, just to, and then he nudged him later on and said, there you go, it's a bit more like you wanted to play. And he didn't like it at all. But I just, just to bring you into the biffo that goes on in your average footy match. Just lift your head up, try hold it up in the clear. So he's okay. So we're going to relax back. Just try hold your head down. Good. Relax, hold it up. So he's still okay, but it's not 100% okay. So we're just going to go over that, eyes open. How many times would you do this before you expect it to be, like really rock solid? Close your eyes. As someone who's had multiple traumas. A few go-rounds. You might do it a few times. Eyes open before you just keep testing them and go, no, nothing there. And close. Okay. Good, eyes to your right. Left. Up and down. Look to your right. Left. Up and down. Good. And look to your right. Left. Up and down. Look to your right. Left. Down. Little breath. Close your eyes. And what we're feeling with Matt too is that as we go through this, we can feel there's tension in the dura. And you can mouth open there. Good, relax the jaw. Now sometimes it's hard to get up the back of the jaw, and his is really sore. Look to your right, look to your left, look up and down, close your eyes. So I'm not going to be a Sunshine Coast footballer and rub it in. Look to your right, left, up and down, close your eyes, right. Good. And little breath. So I've just lift your head up again. Try hold it. Now, it's not bad, but what do we notice here? Hold it. there's a little momentary gap in his reaction time. So we know most likely if we challenge the sutures, he's going to show up with an issue. Little breath. Little breath. Little breath. Little breath. Little bit. Little bit. Little bit. Now I'm being fairly meticulous with Matt because it's, you know, it's significant. And then our centering systems, and then just lift your head up and try hold strong. That's better. So we go both hands on the jaw. So we're going to go universal jaw, and you know, it's just obvious. Just pop your hands away, relax them, and just try hold there. Now what you'll notice straight away is you can engage. Both hands on the jaw. Just try that again. Even before we got there, just see this? Just wobbly. So drop your left hand down. There's our defensive jaw. Now it's not bad, but it's, you know, it's not clear. Just try eyes closed, just to make it interesting. Both hands on the jaw because he's just had this influence. And drop your left hand down. Good. And then we're going to go left hand to right jaw for the pelvic injury complex. Bring that into the picture. And eyes closed, and it shows up more that way. So, excuse me. I'll just grab another finger cotton. Are you okay to continue?
Yep.
Good. So we're going to go mandible. So we unlock the horseshoe, mouth open. First molar spreader. First thing we get, look at my hand, no movement. So I'm going to have to vibrate this to get it to open up. Had some dental work there, a few bridges or something. No. And we'll just gently unlock. Now when I'm unlocking, he's showing up a bit unstable. So I could use an activator just to show you on one, it won't hurt you. And we're just going to find our TMJ, and we're going to come just below that and just adjust down the line. But I'm using it on one ring. And I'm going to do it bilaterally. Now sometimes, guess what? People have got teeth issues and jaw problems and, you know, funky stuff and cross bites. And so sometimes the imbrication will not be equal bilaterally. You may need to do a little bit more on one side. Mouth open there, little breath. Much more movement up top, much more movement. Centering systems, left to right communication, lymphatics, little breath. And little breath. And gallbladder. Wow, red hot, bit tender. He's a rover. You can rub his face in the dirt all day and he'll just come up smiling. Good-o. Bend the knees up. Okay, squeeze the knees together hard as you can. Good, so he's pretty good in the pelvic floor. Squeeze out. What do you do physically, toning-wise?
Doing like some bodyweight gymnastic strength training sort of stuff.
Okay, cool. So, you know, kind of, you know, sort of very efficient body strength. But because he was strong this way, and we just found all that, I'm kind of a bit suspicious, so I'm going to invoke the reactive chain, push out. Good, strong as an ox. Push in. Now he's still strong, but look at this. Look at this, relax. You win all the tests here, I guarantee you. Push out, push out. That is like, wow, I can hardly hold that. Now try this, push in. Now I can push that apart if I wanted to. So it's between the two, big difference in strength. Squeeze, squeeze. So we've still got an imbalance. Squeeze, 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 squeeze. Keep going, keep going, keep going, keep going, keep going. Little breath. Good. And we're going to give this a little flip in here. Take a breath. Cough. Good, thank you. And then diaphragm. Now what I've found with Matt, also when we push up here, is that this cardiac part of the stomach, cardiac area of the stomach, feels like it's up. I'm going to push it up, see if it shows up. It does. So we're going to do a little release on that, hiatus hernia technique. Pushing down, cough, give it a flip. Good. Don't get any reflux, no symptoms. Symptoms, whatever. It's what's going on in function that we're most interested in. Now we had a a defensive jaw. So we're going to go, well, let's just check him because he's wiry and strong. We'll just check the flexibility in his fascial chain. So what are we seeing straight away? So not much. Yeah, you'd think he would have more. So why do you think he would have not much down there? Mouth open. We're going to go masseter temporalis and opposite lateral pterygoid. Same on the other side. Then we're going to repeat the image. We're going to go left to right and right to left. That's the reactivity. Once we've done that, we don't have to repeat that again. We used to. We found you don't have to. It's going to go head right, right to left, and left to right. Head left, left to right, and right to left. And we can check him for torque. And we're going to go here, and all I'm going to do is just put my hand on G medius, okay, on this side, sorry, so that we've got a complete circuit, and I'll just pull him into body torque and see if there's a problem. Yeah, it's not bad, no big deal. Let's go the other way. Go head right, legs left. Keep your hand on your jaw if you can. Good. Hold it. That one's a big problem. So we're going to go there. You don't have to test these things, but you can. So we're going to go right to left and left to right. Now I'm going to swing him back the other way and go left to right and right to left. And then we're going to release, so that's our lock at the cranial end, put tension in the sphenoid, get the cranial and spinal dura to tighten. Now I'm going to unlock it at the other end. Got the greater wings of the sphenoid in my hand. You can get them to hold it if you want it, like that. A little breath. And I'm on the tip of the coccyx. I'm not on the sacrum, I'm on the tip of the coccyx, and I'm going to get hold of it and just gently push it anterior and cephalad. And just rock it. And what I want you to do is, as you breathe, a little breath, just feel for motion. Is it letting go? Don't just go through the motion of doing it, but just try and feel, is it happening? Are we getting a lot more movement this way? Back to centre. Keep your head there. A little breath. So we had a fairly limited flexibility in abduction for him. Pretty common thing for footy players because they all have pelvic injury. Good. Relax there, well done, almost there. So we're going to go to our stair steps. I'm going to release the insertion of the dura. So occiput, C1, C2 particularly. And of course we're trying to influence that bridge between the dura and the fascial system in the upper cervical complex. Give it a little release. Most people go, this is nice. You can do that all day. You've got to be joking. Okay, now I'm going to push into him. Let your head relax. I want it to go floppy because we can go up and look around and we can see, look, there's not much movement there. There's not much movement there, and this side's a bit better. So we're going to push in. I'm just going to lean in with the pressure that he's going to push back at me against. Good, nod the chin. And down, and go a little breath. Walk up through the 4.5 steps, roughly. Thank you, well done. And nodding. Let them do the work if you can. You just need to hold them to account, so to speak. Okay. Nod the chin. Good. And you notice that left side was a bit difficult to release, nod the chin, so we can go over that again. Good. And nodding. Good. Turning your head to the right side. Stretch them around, push around. Get them to push against you as a resist. Turn your head and push. Turn your head to the right, just to this side. Rotate to the right. Just go rotate that way. That's it. Good. And then rotate the left. Good. And then we're going to just give the cervical fascia a little gentle release. not too bad. Up through the interspinous areas. Not too bad. There's a little bit up here at C2, 3. Still there. Good. Relax your legs. Let's go floppy there. Now, did you have any groin strains while you were playing? Look at this.
My calves have always been,
Pretty good.
no, like not been good, like it's always been tight.
Yeah, okay.
Yeah.
So look at his right side. So straight away, came out quite a lot. Yeah. Look at his left side. Not going anywhere. So what I do with his left side is I'd go back and check his iliofemoral, because we did a fascial release on him and it doesn't seem to have released the fascia completely on that side. Let it go if you can. You may have to move the leg into position. Make sure my claw is over the greater trochanter, and I'm going to move it forward. Now you can see what's happening as I try and do this. It's almost like the leg's stuck, the hip's stuck in that position. Good. And this is really tough. This is an old hips and sort of scenario. Let your leg relax. Okay? Straight away. So if you see something, one side just goes straight out, and you're dealing with connective tissue, and you know that our iliofemoral, iliotibial band, capsular, something involvement down here, then go straight to that, because that's probably what it is. The only thing we haven't done, we did both hands on the jaw for universal jaw, right jaw for defensive jaw. We're going to go left hand to right jaw for our pelvic injury complex. So we're going to go here, cool, and hold it out. Now we could, for example, we could test the muscles, couldn't we? So we could get up here on his, we'll go to his left side, to the left QL. Try hold it there if you can. Not a chance. So we could start opening it up. We could test the G medius. We could test his opposite adductor. Lock it in there if you can manage. Not a chance. Bend the knees up. And then what we're going to do is we're going to put tone back into the hypertonic area. So we're going to get onto QL and separate the fibres. We're going to get onto G medius and separate the fibres. We're going to get onto the opposite adductor, separate the fibres. Then we're going to go back, right to left, yeah, and then left to right. Rub the lamina. Give the ischial spine a little stimulation. And then we can come back to this side, test his QL, no problem. And while we're there, we can test the opposite adductor. I don't know about that one. Probably do a bit more there. Good. And it's a bit tender in there. Yeah. So the thing you get, as soon as I get onto those, particularly the L3 to 5 lamina on these lumbar riding reflexes, you can feel the tension in there. Give it a shake. And that's what we may need to turn on to get this adaptive state back to neutral. Good. Just check it again. Lock it in if you can. We'll pass you. So once again, we might do that a few times with Matt. Thank you very much. You were very generous. Thank you. Cool. So hopefully that gives you a key window. Now, if in doubt, do some show and tell. So because the muscles down there are really big, and testing QL is really an easy one to show, and testing the adductor, you're in the position to do it anyway. You just show people, particularly if you're working with sports people who think you're doing weird stuff. No, I'm just getting you stronger again. You want to see it? Okay, and show them. Show them what's going on. Yeah, and what you might find, which what we're seeing with Matt, is he's standing up straighter. Of course he is, because he's actually got tone, back to neutral tone. He can push up rather than this, which was what was happening before. Great. Look at him, look. He's about to do a little dance for us. Thanks for that. Interpretive dance as well. Okay, cool. So what we're going to do now is we'll go to play shop that. So what you need to keep in mind is top rules bottom. Masseter and temporalis and opposite lateral pterygoid will inhibit. Hypertonic here, we're going to have hypotonic left, QL, G medius and opposite adductor. Super simple. Have a go at it. Have a go at it. Test, let's do it all together, but test those, maybe just when you find the complex, test the muscles just to show yourself what's going on. Thank you. Let's play with that for a short while. So we're just going to scan over her system and just have a look at what's been done. She's obviously had a fair bit of work. I might add that this pelvic injury thing is the kind of the end of the defensive protocols. It's really important, but it's one of the things that I tend to sometimes forget about a little bit. I'm not suggesting you should do that, but you know, I'm kind of going, I got all the rest of it sorted. That should work, and sometimes that works. But with people like Matt, where they've played a lot of contact and they've got pelvic injury going on, you know, we need to go over this and really get that tone restored, because they just don't function as well. That, you know, they don't pop up as well. And you can actually, once you watch their movement, you'll see them moving. The ones that have had pelvic injury and it's not been cleared properly, you can see that, you know, they're kind of, they just can't write properly. They can't push up. And we hear a lot about forward head posture in chiropractic techniques, and you know, some of those things I think are really useful. But don't forget, you know, that we've got intrinsic writing systems that may have been turned off through injury. So you've had a fair bit of stuff going on today, so just have Lonnie Tommy will just scan you. Good, eh? Relax there. Good. So we just have a look in here. So one of the things we see with Siobhan is that, you know, there's a bit of heel tension here. So, you know, she hasn't been getting adjusted a lot, or there's a lot of pressure. And if I really dig this heel tension out, what happens sometimes is those legs that were equal, as we unlock this chain, then we start to see what's really underneath it. So with Siobhan, as we unlock the chain, that's what we get. Short stay short. We could pressure test here. Just see if that did the job. Okay. It doesn't. So what are we going to do? It's getting late on Saturday night. What else, if we've got a Atlas profile, what would we do? Sorry? Bite down. Yeah, we could do that. We could bite down left jaw and right jaw and just see if the jaw was involved. And we did that previously, and we could, you know, show that it was actually a jaw thing. We could also just, you know, move up from the Atlas to the occiput, and we could pull the sphenoid away from the occiput and unlock the tension there in the cranial system. Little breath. Can talk. Peter Erickson from Queensland now was originally Dr. Ferreri's research guide. So this is one of his processes, came out of SOT. Okay? So if the atlas doesn't clear, then the tension may be coming from further up. What did we say? They're most likely to have a descending subluxation pattern. So what we're doing is, imagine that's my occiput. So we're just lifting it up, grabbing hold of the, the gull wings, pulling them apart, counter rotation, put them back together. Just take the tension out. It's just, if you've got someone who's had a fair bit of care and it doesn't seem to be holding, just have a look at that. So it's just an addition to your basic 8 that you put in your basic 8 notes. Put check Cantalk, C-A-N-T, Cantalk. So we're going to check Siobhan, she's strong there. She's not strong on the right. Goes to C3 on the right, so we've got a category 1 right. Little breath. Good. Give it a shake. Little breath. Hypertension at L3. And S2, so we're just going to give her a little rubber-dubber. Good. Lymphatic. Only on the left side. So I'm just going to go left and viscera. And if we're really, we know people, we can start hooking up cloacals or pelvic centering and head riding together. Eyes open, close your eyes. Dr. Ferrari used to like to do that. I don't do it very much because people don't kind of, unless I know them, feel very good about me. Leaning on them, little breath. Are you feeling okay about me leaning on you? It's okay. Little breath. Good. Within reason, yeah. Got it. So the other thing about Siobhan's low back is we can feel tension. So she said, I think I've got pelvic injury complex somewhere, and see if you can check it out. Good. Have a lie on your back. And we know that might be the case if we find 2 cloacals, 2 pelvic central reflexes in the same eye option. Good, good. Check her in the clear. We go eyes to your right and eyes to your left. They're okay. Check her leg lengths this way. Push up. Looks a bit shaky, didn't it? Let's check her hips so we can test the G medius for hips. Not so good here. Rotate up, push in. She's had a hip injury in the past with a labral tear. You'll see that a lot on MRI these days, labral tears. They will settle down. They do settle down. How long did yours take to settle down? There you go, 18 months. And you were long distance running, weren't you? Try telling that. All right. Tomorrow, because we're doing limbic system, we'll find out what she was running from. Okay, eyes open, close your eyes. Mark Feldman is not liking my jokes. Little breath. Up and a puff. Good little breath. And eyes open. Good little breath. Good. So they're okay. We'll assume that's okay. We'll just check up here. Just try hold your head. Not too bad. We'll assume that's okay. Just try hold your head back. Good, relax. Then hold it up if you can. It's, it's sort of, there's something. We'll go with that. Both hands on the jaw. She's had all these checked. Mouth, drop your left hand down, sorry. This one still comes up a bit, even though you've had your defensive jaw done today. Okay, so it still comes up a bit. So something's driving this. Something's kind of this to reset so quickly. Was it in relation to or anything like that, or they just checked you in the clear?
Something happening this morning that was pretty traumatic.
Okay. So sometimes, guess what? People don't hold their adjustments. Guess what? It's usually not your fault. You're putting input into a system to move it back towards neutral. And there's only so much you can do. and sometimes the system will reset. So with her, because she's had it done, what we might do there is just go eyes up to your right and eyes up to your left to see if the brain had received this input. And if we go eyes up to the right, the brain goes, I don't know about that. If we look up to your left, this is for some sort of past memory, and yeah, looks like there's an interface here. So we're going to go look up to your left, to right, and left, and just make sure that that pelvic, defensive jaw is cleared. So I'm going to come back and check that tomorrow, but for the purpose of this exercise, we'd already done this correction today. We wanted to just to reinforce it, so I used what we call eye options, which we went through at the beginning of today's program. And we use eye options to install a program, if you like, to reinforce using the visual field, using the visual fascia, reinforce a series of corrections we've already done, or to access something, as the case may be, looking up to the left is for something we've done in the past. And these concepts originally came from neuro-linguistic programming, but the functional neurology people have got a whole story about using the eyes to stimulate certain pathways. Good, so we're going to go pelvic jaw, so we're going to go left hand to right jaw, check it. This is more obvious. And we're going to go, so we go bend the knees, keep the contact. We could put the visual centres in. Not a bad idea. And we're going to go QL, tone in. So it's got a hypertonic QL, so we're going to separate it. And G medius, and opposite adductor. And what we didn't do on the first thing was to stimulate the, ischiopubic area, or that growth junction there. Stimulate, stimulate. So we're going right to left and left to right. Lamina, L3 to 5 particularly, stimulate the writing reflexes, and she's a bit sore in there, a bit tender. Good. Strong, and then we could cross the hands to check for head or craniomandibular centering to pelvis. And the body goes no, so we're going to stimulate here. So we're just going to go pelvic centering and head writing. We know all about this already. Pelvic centering and head writing, pelvic centering and head writing, pelvic centering and head writing. Now the other thing I do with Siobhan is I probably check her out on category 2 with the visual centres in, and just see if there's anything there. Nothing. We go close your eyes, and so nothing. We go, it's dark, not bad. We could go, she's had multiple car accidents. She was a racing car driver at one stage between, inland from Margaret River and Margaret River. So she was the fastest driver on gravel road in the area. Hold it. And looks like there was an issue there. So we go to category 2. Good, eh? Relax there. She was sponsored by Subaru at the time. And still has an infamous reputation. So we're just going to go category 2. So we've got, our muscle reactivity, masseter temporalis. What's the function of that? It locks the skull. Protective. Rotate the temporal bones. Cranial pelvis. Good, right? Little breath. Good. And mouth open. So we've got sphenobasilar. Now, as soon as we hit this lateral pterygoid, it's not nice. So we're not going to go hard. We're just going to turn it on. Stabilise the sphenoid against the temporal bone. Easy correction, just pushing out on the maxilla towards the ear. Little breath. Good. Check the fossas, check the stress in the inguinal ligaments. Definitely right lower fossa. Strong, strong. This one's not, so it's just this side. So she's a anterior nominate syndrome. And so we're going to block, rotate the pelvis back to neutral. ASIS bisects the block for the posterior side. Anterior side goes up towards the ASIS at the level of the trochanter under the ischial tuberosity. That way. Check it. Rotate the block up till it's strong. Not every, posterior rotation or anterior rotation is the same. So we just need to tweak it until the body goes, got it, that's strong. So we had this side was the TMJ reactivity and most likely the splenius capitis reactivity. So we can just turn off that a little bit, little breath. Rotate the temporal bones. For the chiros, just remember the left PI profile. We've got a left PI there, we're going to have a left PI there. If we've got an anterior there, we're going to have an anterior here. Little breath. Toes to nose, get some motion in the reciprocal membranes. Much more movement, still not enough movement though, so we'll just keep going a bit. Very good. And mouth open, we go pterygoids. Yeah, she'll tell you it's a bit ugly up there. Little breath. Little breath. Good. Strong. Both arms up towards me. Check for psoas and or pubic symphysis involvement. So we just pull it upwards. She's pretty good. Maybe she's a little bit, just a little bit on the right. We'll just flick over that psoas lymphatic on the right. Give it a shake. So we're on the lymphatic and on T12. Okay. Vascular at the midpoint of the lambdoid suture. Both arms up. Pretty good. Pretty good. Pretty good. Trim, I can't see. Thank you. Well done. Very good. So we just completed our pelvic injury complex. We missed out that ischiopubic junction. Stimulate that. So we went hypotonic QL, G medius, opposite adductor. Doing that, we should see that our nervous system activates. One of the things you'll see straight away is that people just pop up. Mark said he hadn't been able to do this for years. Things release, things let go. And also what you'll see is the areas that haven't let go. So the areas where they're still subluxated. They've still got loss of function or loss of mobility, which may require other corrections. This section on defence just dovetails in to your module 1, kind of structural complex. So this is kind of all of the structural corrections that you're going to need in your basic case management. There's been questions about what sort of care plan is appropriate. Well, we'll dig into that tomorrow. Dr. Russell Clark's already provided some information. I'm going to bring a chart. I think the thing about care plans is there are some generic ways to go from A to B. Everybody's an individual. So we just keep that in mind. That completes what we had planned to do today. Would anybody else like to volunteer before I hand over to Julie to just kind of have a full reset before we complete? Okay, so let's get you up. So come and have a stand. So what we're going to do is what I want you to do, that's it, this fit young man here, what do you do, to stay fit?
Cycling, that's about it.
Is that right?
Yeah.
Wow. Okay, so he's a big guy.
Big guy.
Yeah, cool. So what I want you to do is fire questions at me as we go through. So we will, steadily and quickly unlock him from basic 8 through to what we did today. So we'll go basic 8, cranial injury, universal jaw, defensive jaw, pelvic injury complex, and category 2 and 3. And we'll do that, in about 15 minutes or 10 minutes. We'll buzz through that just to give you a window into what we could do. Is that okay? Just to kind of complete and wind up what we've been doing. Ladies, I know you had a commitment, so feel free if you need to go. Cool.
Before you start, sorry to interrupt.
That's tomorrow.
That's good. Sorry to interrupt you.
That's all good. Thank you. Cool. That's tomorrow. Now, who wants to do that? Okay, cool. Okay, thank you. So hold this up. Good. And hold this up. Good. So we don't have any obvious gait problems. We can see that he's down on the right. You can see that? So, you know, there's a module 3 scoliosis pattern or something to come, but we can't see anything obvious with him. Just have a little walk on the spot and relax. Just be you. Okay. So, you know, there's a little bit on the right side. We can push here and here and here and here and here, and he's forward up the top. Good. Come and have a lay tummy. Okay, so we're going to go through and release the heel tension. And what we're trying to do here is just get a feeling of where he's at. He's short. He stays short. So we can go up and unlock this. It sort of hasn't really cleared. Okay? We could go, well, let's do it in the dark then. Now, when I say dark, he will have a visual representation of that and other spatial and experiential kind of memories of what dark is. So he'll get it. Doesn't change anything. So what did we learn today? What are 2 things we can do if it's not changing, other than send them home? Sorry? Can't talk? Or we could just check the Team J, couldn't we? We could get him to walk around, bite down, chew and swallow and see what happens. But we could just do can talk, little breath. Good. Okay. Hold it. So, and if you got that happening, it says there's more residual, tension in the cranial meninges than we had sort of thought. So it says the system has been injured or under load, or there's a reason why it would be like that. Relax there. He likes to win. We know that because he had his leg up and said, I'm not going to let you do that. Relax, relax. Keep him in that position, hold it. Now the other thing is that once we've unlocked that extra tension, we may see this protective stuff show up. So inferior occiput, BP sacrum. Okay, and you see that in any significant injury and any brain injury or developmental dysfunction. Relax, I won't hurt you. You can hit me back. Good. And we're going to release S1. Notice the pressure there. I'm not being rough with him, but I'm not fiddling around, and I'm using my body weight. I'm just kind of at the end. Hold it, strong. Hold it. Okay, so he shows up a right category 1. Good little breath. That's not to say anything you had today was wrong. It's just that we're pushing him out of his adaptive state towards neutral. Little breath. He's not there yet. And for some people, it could take some time. Look at the movement here. None. Good. S2, piriformis, lymphatic for piriformis, vascular, lift the occiput. We're going to go, lymphatics on the right shows up. So I could go test them, but I'm just going to go through the whole lot. Give it a shake. And what I'd say with him is, fluid. A bit of fluid volume here, for sure. No offence taken, hopefully. But we'd go, look, he's pretty fit, but I would have said there was congestion in various areas. And he's had a cold. So we're going to go cloacals, close your eyes, little breath. We had 2, so we're going to do top and bottom. Good. Good. Okay, good. Have a lie on your back.
So I've noticed that most of them are 2 anyhow. Do you ever find that there's 1?
Sometimes you will, but not with people of your history. So if you played footy for years, you'd be extremely unusual. Hold it. Good. Hold it. Good. Now the thing we see straight, let your legs relax. What are we seeing? So he's right, he turns out a bit. So we're going to see, and generally speaking that says there's something happening in the left hemipelvis. Because if we test his piriformis, strong. If we test the psoas on that side, not strong. So something's happening over this side that's creating that adaptive state. Good. Try tongue left and right. So he just shows occiput, and that's what will often happen is they'll swing back. And as we rotate his head there, look how far it won't go. I get him into position. Sorry, it's kind of hard to get him, round to do that lateral occiput. Tongue left. I'd even say we didn't really get that as much as I'd like to see it. Try tongue right. Good. We'll pass you. Okay. So we're going to come up here. Close your eyes. Now he got a bit of both here. Little breath. And eyes open. Good. A little breath. Good. Okay, that's good. And just lifting your head up and try hold it. So he's had that done already. We'll just check the reactivity. Hold back. Good, relax. Hold up. Okay, shows up straight away. Now with his pattern standing up, I would have said almost for sure the cranial injury complex was not cleared because he was still going forward. Thank you. Take care. See you in the morning. Eyes open. Little breath. Close your eyes. And open. Close. Good, eyes to your right. Left. Up and down. Good, look to your right. Left. Up and down. Relax there. Look to your right. Left. Up and down. Look to your right. Left. Up and down. Look to your right. Left. Up and down. Little breath. Close your eyes. And look to your right. Left, up, down. Close your eyes, right. And left. And up and down. Good. And we can just check that. Let's lift your head up. It's kind of better, but it's not strong. So I'm just going to, we could go and check the sutures, but they're there. Little breath. Little breath. Little breath. Good. And little breath. Little breath. And little breath. Little breath. Good. So extended cranial injury and pelvic and head riding reflexes. Just try and hold your head now. We're getting stronger. Both hands on the jaw. It's not too bad there, but if we go eyes closed, shows up straight away. And we're going to go drop your left hand down and eyes closed. See the difference? Just go eyes open. See, that's, there's a lock there. Okay, if we go eyes closed, see what happens? Straight away, you just go, okay, we know it's there. We don't have to work too hard. We go left hand to right jaw, pelvic injury complex, eyes open and eyes closed. Eyes closed, because it hasn't been done. So we'll go clear that out. We'll come back to category 2 at the end. So we're going to just check and see, was there an extended universal jaw? So we'll go mouth open, just give it a spread. Eyes closed though. Let's just check it that way, because this one does look like we need to do this a bit. And that's more obvious, so we'll do that. Mouth open there. Little breath. Now his mandible isn't too tight. There's motion there. Just unlock, deimbricate the condyles, maxilla spread. First molar, taking it lateral. Okay, pelvic centering, left and right communication, little breath. Little breath. Lift the parietals. Murphy's point. Cool. Bend the knees up, check the pelvic floor. That's it, good. You squeeze the knees. Now he's got eyes open, he's doing all right, but close your eyes. Okay, squeeze there. We've got to check them eyes open and eyes closed. You don't have to do it all at the same time, but you need to check it. Squeeze there hard as you can. If it's not done, it's not done. And you'll see recidivism happen over time. We were talking about that before, that if you leave things not clear or not quite clear over a period of time, they'll just go back to the previous state of adaptation, which is completely normal because that's what got them to that point in time. Squeeze the knees hard as you can. Hard as you can. Good, not happening. So we're going to push out, get the reactive muscles in. Squeeze, squeeze, squeeze. Now push in. Now we're starting to lock. Close your eyes, keep going, keep going, keep going. I want you to squash my hand. So this is really unstable. So what are we thinking about here, you know, in his youthful age group? This doesn't lock. We've got loss of tone here. We've got ptosis and pressure. We had lymphatic stuff going on. Well, prostate. It's the most common thing for us male things, that we get congested as we get older if the pressure's left to manifest. And we know that, you know, if you do yoga and stretch things out, or you do a lot more, you know, leg opening stuff, you tend to have less pressure. Nevertheless, the pressure will be building. Squeeze there. Good. Number 4, you know, it's the second most common cause of disease in men in Australia today. Squeeze hard as you can. Under cardiovascular disease. Squeeze, squeeze. So do you think we're doing him a favour unlocking this stuff? Absolutely. Squeeze, squeeze, hard as you can. Push, push, push. But you got to go eyes closed though. You get to win this. Okay. So I'm going to put my hand there and I want you to squash my hand. Hard as you can. Keep going, keep going, keep going. It's taking a while. Taking quite a while to get this on. So there's a fair bit of, you know, kind of loss of tone here. Push out. Squeeze hard as you can. Now we're starting to get somewhere. Good. Keep going. Good. Keep going. Little breath. And little breath. Cough. Good. Now I'm going to give him a good nudge here because I want that tone to come up. Little breath. Cough. Little breath. Cough. And I'm going to just check where so he's got ptosis this way, so to the right, most common pattern. Little breath. Cough. Good. I'm going to tuck the fibres, the diaphragm back in. And guess what else we found as we went around the merry-go-round here? What were you doing before? A little bit of movement of the stomach, cephalad. So if we check in here, if we push up, there's a little problem. Little breath. Little breath. Cough, cough. Good. Check it out, clear it out. Good. So we're going defensive jaw. We had eyes closed. Masseter and temporalis and opposite lateral pterygoid. Masseter and temporalis and opposite lateral pterygoid. Do the mirror image. And right to left. Head right. Masseter and temporalis and opposite lateral pterygoid. Good. Turn your head left side. Same thing. Now we could then test for body torque. We could assume it's there, but we could also just go, well, let's just test you. Try hold up. Not bad. Just go the other way. So head to head, the right leg's left. So go around this way. Yep, that's it. Good. Good. It's a complicated neural task after 7 p.m. on Saturday night. Hold it. Now that one shows up really strongly. So we're going to start there. The other one was really not bad, but we're going to start this side, right to left. Yeah, but eyes closed. This is eyes closed. Yeah. Did you do it eyes closed?
I think so.
Yeah. Yeah. So,
I think we did. Yeah.
anyway.
Yeah.
Yeah. So look at the movement. See how so I'm trying to get movement here. It's just, you know, the table's going.
We're going to tip over.
It's all right. I'll catch you. G'day. We don't allow dismounts during seminars. The other way is not a problem. Back to the centre. Little breath. Good. Okay. Good. Nod the chin up. And down and 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 up. And down. Good. And nodding up. And down and up. And down and up. And down and up. And down and up. And down. Now look at the movement here. So this way, no problem. Pretty good. And then we go this way. And this is not so easy. You can see it's very limited movement. And we get trying to go up through 4.5 steps and we're just not getting there. Good nodding. I'm kind of getting up to 3 and then we go to 4 and then the last half, hard. Go the other side, nod the chin. Now you'll notice also I'm leaning in. He's a big guy. There's a lot of pressure here. Good eye. You know? And if you've got a busy practice and you've got lots of people to see, then you want to just conserve your energy. Good, rotate your head around. Good, rotate your head around. Good. Now he's already, like Dr. Julie had already released him, so we're just going to go up in the interspinal spaces, cervical fascia, have a feel of what's happening in the shoulders. Good. Now we had a pelvic injury complex, eyes closed. So we're just going to go get some tone back in. QL, G medius opposite adductor. QL, G medius opposite adductor. QL, G medius to the mirror image. Lumbar riding reflexes. Then check the head and jaw centering to the pelvis. Not so great, so we're going to go eyes closed just there, but it's not bad. Just lug that in. Good, we're done. So the last thing we do with Kim is we'll just check him on category 2. Left jaw, and he's all good, no problem. Close your eyes. And it's not so strong. Not so strong. Right hand on the jaw, left hand down, and eyes closed. Reactivity side to side, so we've got the left category 2, but he's got the two sides are still kind of going, I need to hold this cranial pelvis together. Little breath. So we've gone spinobascular, NL, neurolymphatic, vascular for flexion, the neck flexors and extensors. Flex the feet up. Spinobascular. Get that junction at that sella turcica, flexing and extending. Good. Mouth open. Pterygoid, not too bad. Way worse on the right, little breath. Stabilise the sphenoid against the innominate rotation or the rotation of the temporal bones. Little breath. You can see the right side's really restricted. There's another level to that. Check the fossa, good. Not good on the right lower fossa. Left upper's not bad. You notice I'm just changing the polarity of my hand, positive and negative, just to see if there's anything else here. He does show a little bit on both sides. So we're going to call him a both side pattern. So he's got a PI and an AS. And we're going to check that. We're going to rotate the block up. This block here, the ASIS bisects the block. This one pushes up towards that side under the ischial tuberosity. I'm just going to rotate it in position until he's strong, pretty close. Give him a stretch. Then we're going to go back and just spindle off the TMJ reactivity in the splenius capitis. Little breath. Hang on, go little breath. Sorry, we'll go rotate the temporal bones of the cranial pelvis, the cranial innominates, if you like. NL, NV for the flexors and extensors in the neck. Sphenobascular. No movement, flex the feet up, movement. So, you know, this is going to make a big difference to him if we can get this stuff to lock in. His whole nervous system is going to be healthier. Mouth open there. So we've got a lateral pterygoid involvement because we had sphenobascular. Stabilise the sphenoid against the rotation of the temporal bones. Little breath. Remember, it's all contralateral, the rotation. Left PI, we're going to have a posterior right temporal bone. And right AS, we're going to have a posterior left temporal bone. Good. I'm just going to go back and just do his phenobasilar. Sometimes you may need to just reinforce that flexion extension of the skull. Just go up when there's a lot of tension. We'll just get them to hold better. And we'll check it strong. And then we're going to have a look at his psoas. Both arms up. Give him a stretch, just lean back. Good. Shows up a little short on the left. Flick the lymphatic. Still shows up a little short on the left. So what are we thinking? Therapy localised pubic symphysis. Rotate down from the right. Rotate down from the, he's the left superior pubic symphysis. Both arms up towards me this way. Okay. He looks pretty good now. Thank you.
Too much work for you.
Cool. So just come and have a stand up and make a face at everybody again. Just have a little walk on the spot. Now what you notice with him, relax yourself, look how much he popped up. Okay, straight away. And that's what we want to see. It's kind of like the whole system is kind of locked in distortion. And once we bring it out, everything starts to fire. Thank you very much.
Thanks, Paul.
Okay. Questions that anybody may have before we close for today? Okay, we've got all that too. No questions? Okay, great. So thanks so much for your attention. It's been quite a day. We did try and compress the information down and give you a conceptual kind of window today, rather than a technique, recipe. Because at the end of the day, when you're working on someone, you're going to remember, we want you to remember, I want you to remember, the conceptual process as well as the recipe you're following. Because then you've got more control about where you're going, particularly when you're starting to put this all together, which is what you'll do in the next few weeks, is you'll put module 1 and 2 together and start having a bit of a flow about how we're going with this work and where to take Mrs. Jones, or Kurt might be, people like Kurt, where they've got kind of unusual patterns, but really probably just their craniomandibular system is the key. Thank you very much.
Cheers.
Enjoy your Saturday night.